Good morning, everyone, and welcome to the Rcsi Bahrain Annual Conference of 2022, under the very kind patronage of His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al-Khalifa, Chairman of the Supreme Council of Health. My name is Professor Stephen Atkin, and I'm Head of School of Postgraduate Studies and Research. Next slide, please. Shown here is the agenda of the day. His Excellency will be addressing us next. I will then do another welcome address on behalf of Professor Samir Otoom, who is unable to join us at this time, following which we have 4 keynote speakers and presentations, at the end of which there will be a question and answer session. Following this, there will be the 6 top research abstracts that were submitted to the actual conference, and each will have 10 minutes to speak, but there'll be questions immediately after. Last year we did a winner's announcement, but because of the diverse nature of the presenters, then it would not be possible to actually pick one excellent presentation. Next slide, please. I would now like to invite His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al-Khalifa, Chairman of the Supreme Council of Health. Your Excellency.
Thank you very much. Dr. Samir Otoom, ladies and gentlemen, good morning, distinguished guests. Ladies and gentlemen, it gives me great pleasure to be addressing you today at the 2022 Rcsi Bahrain Annual Research Conference. Continuous research has always been the essence of enhancement and development of all aspects of healthcare. And with the onset of the COVID-19 pandemic, the value and impact of conducting research has multiplied. Although the pandemic unfortunately affected everyone worldwide, it was allowed us to fully establish a national clinical trials unit of Bahrain with the support of the Royal College of Surgeons in Ireland. Medical University of Bahrain that has now completed 3 national clinical trials in response to the needs of the Kingdom of Bahrain. The expertise of the clinical trials unit is now recognized outside of Bahrain, bringing in external research and collaborations. With the development of the new Rcsi Bahrain KHUH Collaborative Clinical and Biomolecular Research Center, this has allowed Rcsi Bahrain to be the forefront of the research for the benefit of the healthcare needs of the Kingdom of Bahrain. I would like to take this opportunity today to extend my sincere thanks to Rcsi Bahrain alumni and nursing students who volunteered their time and efforts to support the fight against the COVID disease. Finally, I would like to congratulate Professor Stephen Atkin for hosting this research conference. I am confident that it will be enriching and terrific showcase of the great research efforts ongoing in Bahrain. Thank you very much.
Your Excellency, thank you very much indeed for your address and your very kind words. Thank you very much. Can I have the next slide? Unfortunately, Professor Otoom cannot be with us at this conference, and therefore I will be giving his welcome speech to you now. Your Excellency, distinguished guests, dear faculty and students, good morning. I'm delighted to welcome you today to the Rcsi Annual Research Conference 2022, hosted in the kind patronage of His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al-Khalifa, Chairman of the Supreme Council of Health. I would like to thank His Excellency for his patronage of the conference and for his ongoing support and guidance on research and other activities in the Kingdom. It is without doubt we have all witnessed the growth of national research output and the impact it had on healthcare policies and regulations in the Kingdom of Bahrain. Continuous research has always been the essence of the enhancement and development of all aspects of healthcare, and is one of the key drivers that underpins Bahrain's Vision 2030. With the recent opening of the Rcsi Bahrain Clinical and Biomolecular Research Centre at King Hamad University Hospital, the Bahrain Oncology Centre, impactful and patient-centred research which addresses key national, regional and global health challenges is at the forefront of our priorities as a university. I'm confident that today's conference will be an enriching showcase of the new knowledge and great ongoing research efforts by our faculty, students and colleagues from different universities. Thank you very much. Can I have the next slide, please? So now to progress with the actual conference, I am genuinely delighted to be able to welcome Professor Fergal O'Brien, Professor of Bioengineering and Regenerative Medicine, Deputy Vice Chancellor for Research and Innovation, Head of Tissue Engineering Research Group, Deputy Director, Advanced Materials and Bioengineering Research. That's quite a mouthful, Fergal, but well deserved. And invite you to give your talk on biomaterial-based delivery of gene therapeutics and stem cells for enhanced repair of bone, cartilage, and other tissues. The floor is yours, Fergal.
Thank you very much, Steve, and thanks to His Excellency for his patronage of today's event. And I must start by saying I was in Bahrain last week and I was at the launch of the Clinical and Biomolecular Research Facility, as well as a number of other events I was at last week. And I'm really, truly excited about the growth of research in Bahrain nationally and in Rcsi Bahrain, and I think it augurs really well for the future. I'm going to talk today about some of the work we do in the Rcsi Tissue Engineering Research Group. And I guess for a lot of the research I talk about, I'll probably leave some open-ended pieces because I think there is opportunities to develop increased collaboration with Bahrain, and I'm thinking particularly in the area of preclinical testing of some of the technologies we've been developing in the Dublin labs in partnership with Bahrain. So as many people, next slide please, might be aware, I head the Tissue Engineering Research Group in Dublin, and the Tissue Engineering Group is a group of about 20 research principal investigators. We have close to 100 researchers, and our general focus is to use biomimetic biomaterials, or what we call scaffolds, and these are essentially 3D porous implants. And if you look at the center of the image that you see in front of you, these porous implants, they're like sponges that when they're implanted into the body, they can act as therapeutics for tissue regeneration. And increasingly, we use them as models for disease, to understand more about disease, and for drug screening. And also, I should give a huge amount of credit to my colleague, Professor Michael Keogh, who's leading a satellite lab based in Bahrain. And this collaboration between Dublin and Bahrain has been working really well. I'll try and give a couple of examples of that as I move forward through the presentation. So we focus now on a whole series of different tissues and organs. I'm not going to go through all of them today. The commonality is the biomimetic biomaterial. We mimic the tissues in the body when we develop these scaffolds or implants. Next slide, please. And if I give you an example, and this is going back about 12 or 13 years ago, taking bone as an example, and I'll stick with bone a little bit because we have a lot of data on bone. So if you look at bone at a simple level, it consists of two things: collagen, a protein, and hydroxyapatite, a ceramic, which gives bone its intrinsic strength. So we did a lot of work over the years trying to figure out the best ways to combine these two materials and to produce a porous implant that would be suitable as a viable alternative to the traditional methods of bone graft. And as people will be aware, there's a lot of problems with existing bone graft treatments when people suffer from large trauma where the bones won't heal, or cancer of the bone, or infection of the bone. And essentially, that's the clinical problem we're trying to target. So essentially, what a surgeon would see is a sheet of the sponge that you see in the petri dish on the left. Our first first clinical trial with this, or preclinical trial with this technology, was in a rabbit radial defect, and what you can see there is an image of the rabbit radius at week 0. On the left, you see the image at week 6 post implantation of the scaffold, and that's very early in the healing stage, and that compares very well to autogenous bone graft, where the bone is taken from the animal itself, mashed up, and put back into the defect. So that was a promising preclinical indication. Next slide, please. And interestingly, our very first clinical case with this was in a horse, because we worked very closely with the veterinary school in University College Dublin. And this was a horse who presented with a large cyst in her mandible. Excuse me, the surgeon came in, and you can see the red box. The surgeon came in, removed that cystic material, implanted the scaffold, and the horse returned back to training. And indeed, we've subsequently used the technology in a number of horses. However, our target was humans, and we received regulatory approval for this technology a number of years ago. Next slide, please. And it's been used subsequently in a number of patients since, and subsequently in maxillofacial defects. And I should say that once we move towards clinical translation, we typically partner with industry, because you can't really just take the technology out of the lab and implant it directly into a patient. You need to scale up the manufacturing process. You need to raise the investment for the clinical studies. So we set up a company to take the technology through to the market. Next slide, please. However, and there is a however, that scaffold on its own, that porous collagen hydroxyapatite implant, isn't going to heal every defect. It'll heal defects of a certain size. So in order to heal the very large defects that we typically see in trauma, an extra stimulus might be required. And like a number of groups worldwide, we've been focusing on things like stem cell delivery, biomolecule delivery, things like antibiotic delivery when we're talking about infection. And the key then is that we need to make sure the scaffolds can deliver the biomolecule stimulus safely, and that we can control the release of the therapeutic. And that's what I'm going to talk about a little bit in the next few slides. So next slide, please. So one molecule that we're particularly interested in is using the scaffold for gene therapy, for gene delivery. And I think we've all probably become more aware of the opportunities in gene therapies with the development of the Covalent vaccines, which is essentially is a gene therapeutic, the mRNA specific vaccine. So what we've been doing is taking these same porous implants, except we're now delivering these gene therapeutics, things like plasmid DNA, siRNA, microRNAs, and messenger RNAs from the scaffold. And our premise is that by delivering a gene on the scaffold, that we can get the cells themselves in the body to produce the therapeutic. So it's essentially the cells act as a drug factory because of the way we manipulate the scaffold. And I'm going to just go through a little bit of the science behind this as I go through the next slides. So next slide, please. So to achieve that, what we have to have are nanoparticles embedded in the scaffold matrix. So you've got the same porous implant as before, except you've now got a nanoparticle. That nanoparticle is complexed with your nucleic acid, so the gene of interest. And when the cells move into this porous implant, and that's what I should say, because it's biomimetic, the cells in the body, in the defect site, move through the porous implant, they grow into it, they populate it, but now they take up those nanoparticles through endocytosis, and then they begin to overexpress that protein. If it's, for example, a plasmid DNA we're delivering, or a messenger RNA, or they silence it if it's something like an siRNA or a microRNA that we're delivering. So if it's a bad effect, we can shut it down. And what we now have, next slide, please, is a whole series of different types of nanoparticles for different indications. And we can control the release kinetics of these cargoes, these genetic cargoes, depending on the composition of the particles we use. And I'm just giving some examples of these particles on this slide. Next slide, please. So to give you an example, and again, for the people who are more interested on the material side, what you see on the slide on the left is the expression profile of the gene expression from the scaffold system. So you get this increase in gene expression up to maybe day 7 to 10 to 14, depending on how we want to control that. And then it begins to drop off over time. And we can manipulate how long a gene is expressed and how long the cells take up that gene by changing the cargo or the nanoparticle composition, and by also controlling how we manipulate the scaffold. And the idea is, next slide please, that if you put that gene-loaded scaffold into a defect, and in this particular example, I'm showing you a rat calvarial defect, so a hole in the rat skull. The scaffold, in this case, loaded with nanoparticles containing green fluorescent protein. It goes into that defect, and at 7 weeks post-implantation, what we can see, because the cells are now fluorescing green, it shows that we're getting whole cell migration, infiltration, and transfection. So that shows proof of concept. Next slide, please. And when we applied that to two genetic cargoes, vascular endothelial growth factor, which recruits blood vessels, and bone morphogenetic protein, which creates bone, what we get is rapidly accelerated bone healing. And on the left-hand side, you can see the empty defect at 4 weeks. In the middle image, the scaffold alone, that's the scaffold beginning to heal the defect. We know that by 8 weeks, it'll complete the filling of that defect. But on our gene-activated system, you can see that it's filled in the defect as early as 4 weeks. And we're now applying that concept. I'm showing bone here for a whole series of different tissue indications, some of which I'll go through as I go through the talk. Something else we can do, next slide please, is shut down things that might be having a negative effect, or such as delivering siRNAs, or potentially to use things like microRNAs where we can target multiple pathways. So one of the reasons we got interested in this area was because we knew that, for example, if we were to deliver microRNA 210, which is one particular molecule, we might be able to target both bone formation and blood vessel recruitment with one molecule. And I'll just give you a case study on this. This is microRNA 133A. So next slide, please. And microRNA 133A is a bad molecule in relation to bone repair because it inhibits RUNX2 production, which is the master transcription factor associated with osteogenesis. So our idea was, could we shut down miR133A from our scaffold systems using nanohydroxyapatite particles? Next slide, please. And what we showed initially in vitro was that if we applied an antagomer, an inhibitor to miR133A, we could increase RUNX2 expression, increase expression of a number of osteogenic factors, and increase matrix mineral deposition. And that's what you're seeing in the bottom slides. Next slide, please. And when we go in vivo, this is again showing a rat calvarial defect. What we see is the presence of the antagomer to 133A really enhances bone repair to a similar level that we saw with using a dual combination of the osteogenic and angiogenic targets. And I have to say, one of the really interesting things about this study is the fact that we saw that the cell type that was predominantly responsible for this effect were macrophages, not stem cells, which were the cells we were targeting, but those macrophage immune cells. And we're really trying to understand the mechanism of this in more detail. Next slide, please. So just to switch tissues briefly and to talk about cartilage repair, one of the problems with cartilage in comparison to bone is that it's got a very heterogeneous structure. And cartilage doesn't just exist on top of the bone. You get a structured interface from the cartilage on the overlying surface of your knees or your hips all the way down to the subchondral bone. So it's an osteochondral tissue with multi-layered, multifaceted, multicellular combination. So to target this, we developed a multi-layered osteochondral graft substitute, which is designed to replicate the natural tissue and has an interconnected pore structure with seamlessly integrated layers, because we need it to act like a sponge to recruit the whole cells. And our premise is that if we could recruit the whole cells into the implant, the composition of the implant itself would direct tissue formation in the right regions. Next slide, please. And that's what we found. We found initially we tested that technology in rabbits. We subsequently tested it in goats at time points up to 12 months. Next slide, please. And interestingly, our very first clinical case, again with this technology, was in a horse, a show jumper, where we used the technology to treat a show jumper, young show jumper, who had presented with a really nasty condition called osteochondritis dissecans. And when she did the horse that was treated with that scaffold, it worked very, very effectively, and she subsequently returned to training. But again, it was a good case study for us. Horses weren't our target. Next slide. So we have just finished a human clinical study carried out in the Sports Surgery Clinic here in Dublin in partnership with the Kappa National Orthopaedic Hospital. And what we're seeing is that and these are males in their 30s and 40s who have had sports injuries typically. But what we're seeing here is that the scaffold works as effectively as using an osteochondral implant taken from the patient themselves. So very positive results. Next slide. And we have, I should add, we have licensed that technology to a company in the UK who are bringing it to the market. And I should say again, though, while it's promising, that technology will only work for certain size defects. So again, similar to the concept with bone, we're also focusing on delivering therapeutics from that construct in order to enhance its regenerative capacity. This slide shows an example of the scaffold delivering 3 transcription factors, SOX5, 6, and 9, and it's showing that we can enhance cartilage formation on the scaffold system with this quite complex gene delivery system. Next slide, please. But one of the challenges with cartilage, and anyone who has suffered from osteoarthritis will be aware that it's not just about the cartilage degrading or the cartilage losing its potential to form. It's also to do with the resultant inflammatory effect. So what we've also been doing is trying to target the inflammatory process by using things like siRNA, in this case, to turn off the N65, P65 subunit of the NF-kappa B complex in order to shut down the inflammatory process and to enhance cartilage repair. And I think for cartilage in particular, the right solution is going to require both the anti-inflammatory as well as the pro-chondrogenic approach. Next slide, please. And I'm going to finish off over the next few slides to talk a little bit about how we've moved to different tissues with the same premise, mimicking the tissues in the body, depending on looking at their composition, and then designing implants that have the composition and the architecture designed to try and mimic these tissues in order to repair them. So we've had some success, for example, with tubular implants in the area of blood vessels, urethra, and respiratory applications. But I think the one that's of most relevance probably in Bahrain is the work that we're doing in the area of skin and in nerve regeneration. So for skin, a bit like cartilage, it's a multi-layered tissue, and what we've designed is a material that mimics both the epidermis and the dermal layer beneath that. Next slide, please. And that scaffold implant, that bilayered material, has shown some promise on its own, but in order to enhance its regenerative capacity, what we've been doing is using gene therapeutics to enhance its vascularization potential, limit fibrosis, and to improve repair. So from an angiogenesis perspective, we're delivering different angiogenic molecules. We're also delivering siRNAs to inhibit fibrosis. Next slide, please. And this is actually work that was carried out by Ashang Luang Lueva, who was a Dillman PhD student working between Dublin and Bahrain. And many people will be aware of Ashang's current work with Professor Michael Kyo. So in this case, we delivered SDF1 alpha, stronal derived factor 1 alpha, which is a really interesting molecule. And what we can see is that we can enhance angiogenesis, blood vessel formation on our scaffolds with the delivery of this molecule. Next slide, please. Next slide again, please. And we've published that study. We've also shown, and this is a recent study from Michael's lab, we've also shown that we can restore the proangiogenic potential of diabetic cells using this SDF1 alpha system. And a big interest now for us is in this area of diabetic wound healing, because I think there's major opportunities in this particular area. Next slide, please. And also in Michael's lab, we've been delivering this anti-aging beta cloto molecule on the scaffolds, which is also promoting a regenerative response using human adipose-derived stem cells. And this is one of the technologies that we're proposing to test preclinically in partnership with the BDF facility. And I have to say, I was hugely impressed with this facility when I was out there with Michael last week. I think great opportunities present. Next slide, please. And we've, as I mentioned, we're also delivering things like siRNA to inhibit negative factors like fibrosis. In this case, delivering MMP9 to shut down matrix metalloproteases, which are connected with impaired healing in diabetic foot ulcers. Next slide, please. And the last example I want to give is the work that we're doing in the area of peripheral nerve repair. And I'm part of the leadership team of the Amber Centre, which is an SFI funded centre, Science Foundation Ireland funded centre, in partnership with industry. So we get some money from Science Foundation Ireland, from the Irish government, but we get a lot more money also from industry. And I think the real key here is that co-funding model. The companies love the idea of the government providing some funding, and then they benefit by getting some of the funding as long as they put money back into it themselves. And I should say, in a lot of these projects, the university owns the intellectual property and the company gets first right of refusal. Excuse me. So we've had a really successful project with Integra Life Sciences, whereby we've developed a construct for peripheral nerve repair. And what you see there is a tubular construct which helps to connect the ends of damaged or lacerated nerves. And I guess the science is in the middle of that tube, because we've got a matrix combination in that tube which enhances peripheral nerve repair. Next slide, please. And what we've seen is that by providing, and this is now patented so I can disclose the combination of matrix components, it's collagen, chondroitin, sulfate, fibronectin, and 2 different types of laminins. Very, very defined composition. But in that tube, we can direct healing in peripheral nerves to a similar level to autograft, to nerve grafts. Next slide. And we've just published that study, and it's got quite a bit of media attention internationally, because we're getting really enhanced healing without growth factors or gene therapeutics. Next slide. And I will say, we can see though that we can potentially target much larger defects if we deliver growth factors. Next slide. Or gene therapeutics. So I think there's a real opportunity in this space, and we're doing a lot of work in this area. And of course, the obvious follow-on area to that, next slide, please. I think this is the last technical slide, is to see, can we scale up from peripheral nerves to target the central nervous system? And we started a project, it's running about 3 years now, and we're starting to make significant progress with the Irish Rugby Football Union Charitable Trust. And again, this is co-funded by the taxpayer through Science Foundation Ireland. So the charity is benefiting through the co-funding model, and then the government benefits because we can maximize the impact of our taxpayer euros that are put back into it. But of course, spinal cord injury is the holy grail in regenerative medicine, and you really need a complex, multifaceted approach. So how we're targeting that is a multifunctional scaffold system. It's biomimetic. It enhances a neuronal activity. It also, we're targeting the glial scar which forms with spinal cord injury. And very interestingly, it's electroconductive. And this is probably the biggest growth area in our group at the moment, is developing materials that can carry electrical stimuli and responsible to electrical stimuli. And next slide, please. We've just published our first paper from this spinal cord project. I'm very optimistic of where this project is beginning to go, and I hope maybe in subsequent years I'll tell you more about it. And with that, final slide, I think. I'd like to thank everyone for their attention, thank all the wonderful researchers that contribute to this research, and of course, critically, the funding bodies, especially our national funding bodies in Ireland, Science Foundation Ireland, the Health Research Board and Enterprise Ireland, without whom we couldn't carry out this research. So thank you very much for your attention, and I'll be delighted to answer questions in the Q&A session.
Fergal, thank you so much. That was a fascinating and really thought-provoking talk with such amazing potential for the repair of nerves, which I know hasn't been done before. So yes, there is a question and answer session, probably around about 10:30 after our final speaker. And I would encourage all the audience to actually send in their questions, please, so I can present those questions to our presenters at the question and answer session. Thanks very much indeed, Fergal. Could I have the next slide, please? Next, I'd like to ask Professor Rebecca Jester, who is head of our School of Nursing and Midwifery here at Rcsi Bahrain, to present her presentation on the relationship between obesity and primary total knee replacement, a scoping review. Rebecca, the floor is yours.
Thank you very much, Steve. Just to say that I really enjoyed Professor O'Brien's presentation, and having worked in orthopaedics for about 30 years and 20 years of that as an advanced nurse practitioner in orthopaedics, I'm really excited about the research that you're doing there in terms of being able to provide solutions to cartilage regeneration, cartilage replacement. So that sounds very exciting. So could I have the next slide, please? So I joined Rcsi Bahrain in July last year, and I came from being predominantly heading up a health and social care sciences research centre in the UK. So I have a couple of other things that I get on with as well as my full-time job, as we all do. So I have an emeritus professor of nursing position in my former university, and I'm very much involved in the Orthopaedic and Trauma Nursing Journal. I have an adjunct professorship at the University of Southern Denmark in clinical orthopaedics, and I'm an international advisor to the Hong Kong College of Orthopaedics with their Advanced Nurse Practitioner Fellowship scheme. Next slide, please. I'd like to up front acknowledge Amanda Rodney, who was my research assistant and supported me in this review. So thank you to Amanda. Next slide, please. So what I'm presenting to you today is a scoping review that was published last year, actually, and some of you, lots of you will be familiar with systematic reviews with meta-analyses, but in the last sort of decade, it's becoming increasingly popular to either do a scoping literature review ahead of doing a full systematic review, or sometimes instead of. So this presentation in one way is to introduce you to the sort of methodology of a scoping review, but also to present the findings of this scoping review. So primary total knee replacement is one of the most commonly performed elective ortho procedures globally, and many of the patients that undergo this type of surgery are overweight or obese, or indeed morbidly obese. And the most common reason for patients requiring a primary total knee replacement is osteoarthritis. It links back into Fergal's research. And 98% of the replacements that were carried out in England and Wales, according to the National Joint Registry, attribute osteoarthritis for the reason for replacement. So there's a much smaller number of patients, typically those that have got rheumatoid arthritis, that do need replacement of the knee joint. Next slide, please. So here is just a reminder, and it's just of how osteoarthritis can absolutely destroy patients' joints. So you'll see here the total loss of joint space, the osteophytes, the genovarus deformity of the knees. But what we see on the human side as practitioners is the amount of pain and disability and the reduction in quality of life and the ability to go about their work and their activities. So it really is a destructive process, both physically and socially and psychologically. Next slide, please. So increasing numbers of people requiring total knee replacement is a global challenge in the developed world and increasingly in the developing world. But with total knee replacement inpatient cost exceeding $9 billion in 2008 in the USA alone, and it accounts for the highest aggregate cost among the 10 procedures for which demand is growing fastest. So between 2005 and 2030, which is just around the corner, the demand for primary total knee replacements in the US alone is projected to grow by 673%, or 3.48 million procedures annually. So Professor O'Brien, there's plenty of scope for your materials there to help with this. So next slide, please. So obesity is known to be a risk factor contributing to osteoarthritis due to increased weight load and altered mechanical axes on the weight-bearing joints, including the knee joint. Next slide, please. So the World Health Organization divides obesity into 3 classifications. So obese 1 is a body mass index of 30 to 34.9, obese 2, 35 to 39.9, and obese 3 is a body mass index of the equivalent of 40 or above. And outside of that, the WHO classifies being overweight as between 25 to 29.9 BMI. I would just like to add that this is the WHO classification. A number of countries have their own classifications and their own BMI scales. So, for example, the Chinese version and the Hong Kong version have much lower ranges in terms of classifying obesity. And that's a study that I've recently been involved in, looking at the predictive ability of BMI in terms of the development of diabetes. Next slide, please. So the average body mass index of patients undergoing primary total knee replacement in the UK in 2017 was 30.92, which is obese. And 67% of the patients who underwent TKR in this year were either overweight or obese. So I can tell you from my clinical experience of working in partnership with patients now for about 20 years before they have their knee replacements and following them up after their knee replacements, is that in certain areas in the UK, I was working in the Midlands with high levels of deprivation. So the vast majority of our patients had a BMI of 40 plus, and one of my patients who had bilateral knee replacements, her BMI was actually 60. So I just want you to sort of get a sort of clinical view of how this translates into practice as well. So what happened is the clinical commissioning groups back in the UK decided that they needed to impose, and I've used the term arbitrary, maybe rather sort of controversially, thresholds for total knee replacement surgery. So basically, the clinical commissioning groups that pay NHS hospitals to conduct this type of surgery said, we won't pay for patients to have knee replacements if their body mass index is either 35 in some parts of the country, in other parts of the country it was 40. Now this obviously raised a major alarm bell for us as clinicians, because we were then faced with a situation that we've got many patients who exceed those thresholds, who have end-stage osteoarthritis, who are in terrible pain, terrible disability, unable to mobilise. And the commissioning groups were saying you can't do their knee replacements. So being a pragmatist and somebody who likes to get research into practice and to influence policy, I decided I needed to look into this. So next slide, please. So I actually set about developing a scoping review, and the aim of that scoping review was to establish if obesity influences clinical outcomes and cost following a primary knee replacement in the short, medium and long term, and also to find out if obese patients gain or lose weight following total knee replacement, and also if obesity contributes to the need for a total knee replacement. Next slide, please. So what is a scoping review? As I said, most of you will be familiar with systematic reviews with or without meta-analyses. You may have been involved in some integrative reviews, but scoping reviews are still fairly new to a lot of people. So a scoping review has been defined as a process of mapping the existing literature or evidence base and to identify parameters and gaps in a body of literature. One fundamental trait of scoping reviews, which differ from other types of systematic reviews, is the purpose is to provide an overview of what information is available, rather than a focus on the quality of the included studies. Next slide, please. However, a scoping review must still be done in a systematic way to ensure rigour and reporting of findings. Remember that unless we follow a systematic approach to any review, we run the risk of introducing bias into our reviews and misreporting findings. Next slide, please. So the 5 stages of a scoping review are, first of all, to identify the review question, identify the relevant studies, the study selection, charting the data, and then collating, summarise and reporting those results. Next slide, please. So the review questions were: does obesity influence clinical outcomes and cost following primary TKR in the short, medium and long term? Does obesity contribute to the need for TKR? Do obese patients gain, maintain or lose weight following their TKR? Next slide, please. So the search criteria were primary research papers and review papers from 1999 to 2019. And the databases that we included were Medline, Spinal, Web of Science, Cochrane and PsycInfo, which was carried out in 2019. Next slide, please. The findings from the search revealed 104 full papers, and from that, after exclusions, following full text review, we included 71 research papers in this review. The papers originated from 17 countries, with the largest number of papers coming out of the USA and then the UK. Next slide, please. You will see from this graph the number of studies by country over the time span of the review period. It's probably no surprise to us that most of the studies were coming out of the USA and the UK. That's because of known levels of obesity and morbid obesity in those countries, and also the number of total knee replacements that are carried out in that area. But I guess what was somewhat surprising to me was the spread of the global issue here. So we can see that we go from Australia, Europe, China, here in the Middle East with Saudi Arabia and Turkey as well. So it really is a global problem that is being revealed in studies being published in this field. Next slide, please. Could I have the next slide, please? Thank you. One of the things I wanted to point out about the studies that we included were if these studies used the WHO classification of obesity that I discussed earlier in the presentation. And what was somewhat alarming was that the majority of the studies didn't use the WHO classifications to define their sample populations in terms of the obesity classifications. And they instead tended to use arbitrary thresholds of obesity, and that then makes us question the sort of rigour of the studies carried out, and emphasises the importance of, when we're doing research related to obesity, to be sure that we're using, you know, agreed and validated criteria for classification. So next slide, please. So the number of study outcomes. So in orthopedics, we obviously look at what we call short, medium and long-term outcomes. So clearly in the short-term outcomes, we're looking for things like early superficial surgical site infections. We're looking at DVTs, PEs, VTEs. But in the longer term, we're looking at osteolysis and loosening of the prosthesis, requiring revision surgery. But we're also interested in not only the sort of, if you like, medical outcomes, but we also need, importantly, to look at it from the patient's perspective. And obviously, patient-reported outcome measures such as Oxford knee scores and Oxford hip scores and the international knee scores are very, very important to look at patients' subjective view of how well or not well that they're doing after their knee replacement. And one of the things that I think a lot of the public aren't aware of is that after primary knee replacement, about 20% of patients still experience knee pain and in fact are quite dissatisfied with the outcome of their knee replacements. But you can see here the sort of spread of outcomes that were included in the studies that we included in this review. So next slide, please. So just to say that you would have seen a miscellaneous category in that graph, and I just wanted to point out what miscellaneous, what was included in there, which was the association between obesity and age, at which total knee replacement is undertaken. This was something very important that came out in the review, is that sadly patients are becoming, patients are younger and younger when they're being referred to us with end stage osteoarthritis and requiring a knee replacement. So patients in their late 30s, early 40s are not uncommon now. So the relationship between a projected growth in obesity and the incidence of TKR and the risk of having a TKR are some of the outcomes that were in the miscellaneous category. Next slide, please. So the length of follow-up. So the number and type of outcomes included in each study varied considerably, and often there was a lack of justification of the primary outcome measure chosen. So to us researchers, it's this sort of issue of data fishing and not being transparent about what is your primary outcome measure from the beginning of any study, and certainly that was found in quite a number of the studies included in this review. The type of outcomes included were, of course, associated with the length of follow-up. So typically those with a follow-up period of less than 3 months, focused on intraoperative factors, early post-operative complications, length of hospital stay and readmission rates, particularly at the 30-day post-op period. Those studies with longer follow-up period included changes in BMI and weight, implant issues and incidence of revision surgery. Next slide, please. So one of the obviously review questions was, do patients lose weight, gain weight, or maintain their weight following knee replacement? So what I can tell you from a clinician perspective is a lot of patients who come to us that are obese or morbidly obese, that when we talk to them about this preoperatively, they are convinced that when they have their knee replacement that they will definitely lose weight. They'll tell us that I'm going to be more active after my knee replacement, and because I'm more active, I will lose weight. And unfortunately, that is not the case. And just having a knee replacement and being more active doesn't result in behaviour changes and associated weight loss, unfortunately. So within the review, we identified 8 studies that reported on weight change before and after knee replacement. And the studies referred to clinically significant weight gain or weight loss, which is more than 5% of the patient's baseline weight. So 3 studies reported a higher percentage losing weight than gaining weight, but 4 studies reported obese patients gaining weight, and 1 study reported morbidly obese patients largely return to their baseline BMI postoperatively. So that affirmed the case that in terms of patient education and in terms of strategies to help patients with their weight loss and weight management, it's not going to be an automatic weight loss after knee replacement. Next slide, please. So the impact of obesity on outcomes following total knee replacement. So interestingly, 40 studies reported no difference between obese and non-obese participants, including some where the outcomes of the obese patients were better than their non-obese comparators. 30 studies did report worse outcomes for obese participants compared to their non-obese comparators. Next slide, please. Obesity influencing the need for a total knee replacement was another of the scoping questions. So 7 studies in the review reported on the relationship between obesity and the predicted need for a total knee replacement. All of the studies reported statistically significant associations between increased BMI and obesity with the need for a total knee replacement. And the next finding was absolutely staggering for me, in that people with a body mass index of 40 and above have a 32.73% increased risk than a non-obese person of needing a total knee replacement. So let's just take a second to reflect on that finding, that a BMI of 40 or above increases your risk of needing a knee replacement by over 32 times. Next slide, please. So the impact of obesity on cost. So as clinical researchers, we can never ignore including some form of an economic analysis in our studies. So quite often when we're designing RCTs to compare interventions, we need to have a parallel economic analysis running along the side. In this review, 4 studies included economic analyses, and all demonstrated that total knee replacement costs for obese and morbidly obese patients were higher than for normal weight patients. Hospital resource consumption was 7% higher in morbidly obese patients compared to their non-obese patient comparators. Next slide, please. So what are the conclusions and recommendations from this scoping review? So the scoping review found that there is mixed evidence regarding if obesity and morbid obesity impacts on outcomes and the incidence of complications following a total knee replacement. And this challenged the legitimacy of an application of an arbitrary BMI threshold. So you may remember at the beginning of this presentation that the impetus for me carrying out with this review was that I was concerned that patients were being denied access to total knee replacements based on thresholds imposed by clinical commissioning groups. This review actually demonstrated that there is no solid evidence base to say that obese patients and morbidly obese patients will have worse outcomes than normal weight patients. There's mixed evidence. It does, however, say that there will be an increased cost, and that has to be borne into consideration. It does mean, though, that obese patients need to be fully informed of their potential increased risk of certain complications, and that they may have poorer outcomes, not necessarily always, but they do have a risk of poorer outcomes compared to non-obese counterparts. And we must include this as part of the consent process to make sure their consent is fully informed. Next slide, please. Patients should be advised that weight loss will not automatically happen just because their mobility increases following a knee replacement. There is little evidence about effective methods of support and intervention for weight loss in this group of patients, and there is an urgent need to generate this evidence. Healthcare professionals in primary and specialist orthopaedic services need education and training to support these patients to lose weight and sustain weight loss. Next slide, please. The review also highlights the need for urgent public health intervention regarding weight management in early adulthood and to reduce risk of developing end-stage or osteoarthritis in the knee joints, necessitating knee replacement in middle or older age. So we really do need to be focusing our attention on targeting young people, children, adolescents and young people about the risks of obesity, not only in terms of diabetes, cancer and cardiovascular disease, but also on the impact on the musculoskeletal system. Next slide, please. There are some references there that I've used within this presentation. Next slide, please. In fact, I'd just like to say thank you very much for listening to the presentation, and I'll be delighted to take any questions in the Q&A session.
Thank you very much. That was absolutely fascinating, I have to say. And I'm looking forward to the Q&A session because I'm sure it's going to generate quite a few questions. I'd now like to progress to our third presentation from Professor Alexandra Butler and Professor Shahriar Khattak on beta cells for diabetes cure. Over to you, Alex and Shahriar.
Thank you for the kind invitation to speak at the Rcsi Annual Research Conference. This talk will be shared between myself and my colleague, Dr. Shahriar Khattak, and we will be discussing our ongoing work focused upon beta cells for diabetes cure. So, to set the scene, in this schematic of pancreas, islets are scattered throughout the exocrine compartment. In health, there are about 1 million islets, and each is a highly vascularized and highly innervated unit with a well-defined structure. As is shown in this cross-section, insulin-secreting beta cells and glucagon-secreting alpha cells form the majority of islet endocrine cells, with somatostatin, ghrelin, and pancreatic polypeptide forming a minority. Because of its deficiency in diabetes, much work has focused on the beta cell. As can be seen here, in comparison to a normal healthy islet, here stained for insulin, beta cell mass reduction of approximately 65% occurs in type 2 diabetes and approximately 98% in type 1 diabetes. Insulin is, of course, a very effective treatment for diabetes, absolutely essential in type 1 diabetes and more frequently required with disease progression in type 2 diabetes. But it is inconvenient, needs careful management, and can have negative side effects. Ideally, therefore, the goal is to move beyond a treatment to a cure. This is not a novel concept, as whole pancreas transplant and islet cell transplants have been tried over the years with varying success. But there are limited organs available. They have a limited lifespan, and the patient must remain on lifelong immunosuppression. Which is why the concept of stem cell-derived beta cells is so appealing, as theoretically there is an unlimited supply, though especially in type 1 diabetes, there is still a need to protect them from immune attack, and hence the need for encapsulation. Any encapsulation device must have certain properties to maintain cell viability. It must be inert, it must remain in place without migrating, there must be an adequate blood supply, and pore size is critical. Now, there is a great deal of interest in curing diabetes with stem cells, and Doug Melton, for example, a world leader in stem cell technology based at Harvard University in Boston, has sold his startup company that produces stem cell-derived beta cells called Sema Therapeutics to Vertex a couple of years ago for $950 million. And Vertex are actively working on their encapsulation technology. Another company, ViaCyte, based in San Diego, California, is having some success at implanting stem cell-derived beta cells into their implantable devices. However, even if these devices are proven to work, the major drawback of these encapsulation devices is their huge cost. So here at Rcsi Bahrain, in collaboration with Sparamex, a UK-based company, I am working on a novel idea for encapsulation using Exons, which are plant-derived sporopollenins. These are readily available, they're inexpensive, and they can be procured in large quantities. We began with in vitro work, showing that Exons stick to INS1 cells, which is a rat insulinoma cell line in 2D culture, but they don't interfere with cell growth and replication. Next, we showed that Exons also preferentially associate with the surface of both isolated mouse and human islets. And importantly, when exon-covered mouse islets were subjected to glucose-stimulated insulin secretion, a similar response was seen in exon-coated versus non-coated isolated mouse islets, showing that there is no interference with islet function. Because of the difficulty in sourcing rodent and/or human islets, we utilized a hanging drop technique to turn our 2D cell culture of INS1 cells into 3D pseudo-islets. Exons also had an affinity for sticking to these pseudo-islets, and again, importantly, there was no impact on glucose-stimulated insulin secretion in the exon-coated versus non-coated pseudo-islets. The next question we addressed was, are the exons inert, or do they cause inflammation or a fibrotic foreign body reaction, as is the case with many materials proposed as potential encapsulation devices? To address this question, we performed in vivo experiments in mice, injecting them subcutaneously with a mixture of the exons in saline. And here you can see the site of injection. We sacrificed the animals at 10 days, 4 weeks, and 12 weeks to encompass time periods where acute, subacute, and chronic inflammation would be apparent. This next slide shows an H&E stained section where you can see the epidermis, dermis, and subcutaneous tissue of the mouse with the injected exons shown here. And I think you can appreciate at this power that there is no inflammation or fibrosis apparent at 10 days. Here is a higher power view from another mouse, also at 10 days. And when we take it out to 12 weeks, still there is no inflammation or fibrosis apparent. We also collected organs from the mice and checked sections to identify whether there was any migration of exons from the site of injection, and found none. So, observations from this in vivo safety experiment are that exons are inert in vivo, remain at the site of injection with no migration, and therefore potentially they represent an excellent biomaterial for cell encapsulation. I will now hand over to my colleague, Dr. Shahryar, who will discuss differentiating stem cell-derived beta cells as we aim to partner this encapsulation work with the stem cell-derived beta cells produced by him and his team. Thank you.
Thank you, Alexandra. So my lab is Stem Cell and Genome Engineering Lab at Rcsi, Bahrain, and we are utilizing pluripotent stem cell and genome engineering tools for disease modeling and potential cellular therapy approaches for diabetes and neurological disorders. So what are pluripotent stem cells? So these are two different types of stem cells. One are known as the embryonic stem cells, and the others are called the induced pluripotent stem cells. Embryonic stem cells, as the slide shows, are isolated from the inner cell mass of a blastocyst stage embryo, both in mice and also in humans. So you remove the inner cell mass and culture it. And as you can see in the left side of the slide, that they can grow in a dish and then they become immortal. Once they're immortal, you can just sway them to derive any other cell type of the body. On the other hand, the iPS cells or the induced pluripotent stem cells are created by introduction of the reprogramming factor, as shown is in point number 2 on the right side. So these are called the reprogramming factors, or commonly known as Yamanaka factors. So these are a set of 4 or 5 transcription factors that, when introduced into a somatic cell or an adult stem cell, can convert these cells into pluripotent stage. So as indicated here, these cells then can generate all the different cell types of the body. Now, how are we going to utilize these for making pancreatic beta cells? So as you can see in the next slide here, is that you can take these iPS cells or embryonic stem cells and then just differentiate them into pancreatic progenitors or beta cells, encapsulate them, and then transplant them into the patient. Now this seems very trivial and simple, but it takes advantage of the developmental pathways that we start, as shown in the lower part of the slide, is that we start with the pluripotent stem cells and we go stepwise as the development of the pancreas takes place. So we go into the definitive endoderm, the primitive gut tube, and so on until we reach the endocrine precursors and then the beta cells. Now, as I mentioned, that they take advantage of the development pathway. So I'm just going to show the protocol that we use here in the lab, is that we start with the pluripotent stem cells and different stages are shown on the top. And then we end up with SC beta, which is called the stem cell derived beta cells. So just please keep in mind this kind of chart that on the top of the circles, like we have these different stages, and then we have the different pathways that are involved, and by activating or inhibiting a certain pathway, we can reach to the next stage and our goal. Now, in the cell culture, in the next slide, you can see that they have we have an option of 2D cell culture as well as 3D cell culture. So in the 2D, we can generate the beta cells, but as we know that and also Alexandra mentioned that the clinical trials are going on, and so we would need a huge quantity of cells to be transplanted into a patient based on their age, based on their weight. So in that case, we have to transition into a 3D system, which is most likely the bioreactors, so that we can achieve our goal of a higher amount of cells, transplantable cells, in a shortest possible and most economical way. So we also, in the lab, transitioned to a 3D system where we took the cells from the 2D, the pluripotent stem cells, and self-aggregated them as shown in C in the bottom. And then we went into a spinner flask and then cultured them and grew them in a spinner flask and then directly differentiated them into a pancreatic beta cell. So the system we used is these two flasks. So these are called the spinner flasks. And you can appreciate that the spinner on the left comes in two volumes. One is a 150 ml culture volume, and the other is a 300 ml culture volume. On the right, these are smaller, which we call kind of the startups, or when we are establishing a protocol or when we want to tweak some protocols in order to save resources, we start with a smaller version. And these smaller versions come in 30 ml and 100 ml versions. So I'm going to talk about the two differentiations that were run in parallel. One was done in a 300 ml flask, and the other one was done in a 30 ml bioreactor or 30 ml flask. At each stages, as I mentioned, we have previously, so we have quality controls. And in the quality controls, we have a cluster morphology that we looked at the 3D clusters and how they behave and what different types of things we achieve. Also, on top of that, we are doing flow cytometry analysis for the protein expression of the bona fide markers that are present at each different specific stages of development, and in this case, of the generation of the pancreatic beta cells. At the end of all that, we do a functional test. Now, the functional test is called GSIS, and it's basically we are checking the responsiveness of the beta cells towards glucose. And if we challenge them with glucose, if they would secrete insulin. Now, in this case, as you can see the scheme here, so we have two glucose challenges. We have a low glucose, and then followed by a high glucose, and then low glucose and high glucose. And in the end, we have the depolarization, where we just put in the KCl and depolarize the membranes of the beta cells so that they can just secrete all their insulin content out into the media. So I'll just show you these also at the end, how we achieve that. Now here, I'm just going to start with the morphologies of the different cell types. So you can see on the top left is the stages and the day. So this is stage 1, day 1. And on the top, these circles represent the different developmental stages as we go or as we progress forward. On the left side, you see the 300 ml flask cultures, and on the right side, you see the 30 ml flask. Now, this is a pluripotent stem cell stage. So this is basically when we adopt our 2D cell culture into a 3D cluster formation. So these are round kind of spherical, let's say like spheroids or embryoid bodies or something like this, but they're not really like those, but these are just a cluster of pluripotent stem cell, which is between 200 to 300 microns in diameter. And they have this kind of a shape. So you can see that they are there. So when going further, you see at the definitive endoderm stage, we see some sort of necrotic scars. Like, so you see these black circles in the middle, as well as in the background, you see some cell debris. So which is very common to see at this sort of stage. If you don't see this particular characteristic, then you should just stop the protocol and you should just go back to the pluripotent stem cell stage and start all over again. And this holds true for all the morphological characterizations that I'm going to show you in the next slide. So in the next one, at the stage 3, day 1, they attain this kind of popcorn-like morphology. And if the Harvard at the Melton lab call it like the flowering, but to me it looks like that they more resemble like popcorn. So but irrespective of what you call them, the morphology of the cells, of the clusters, they look like this. And then after 2 days, surprisingly, they just get back to the spherical shape. And this is very, very amazing. So, and if they don't get back to this spherical shape in this early pancreatic progenitor stage, there's something going wrong with the protocol. So you have to go back again and start all over again. So it's a lot of work, but once we establish it with the cell lines of interest, and it goes fine, so you have a good quality control based on morphology to see if you are going in the right direction. The late pancreatic progenitors this is called the budding stage. So you can see that there are these small buds protruding out of these clusters. And also they have kind of a crater-like morphology. So they have like these craters being formed. Now, in this case, if you see a lot of budding or overbudding, then the culture is going to give rise to more alpha cells, as well as they are going to make a lot of polyhormonal cells and not just beta cells that are purely secreting insulin. Now we end up with the endocrine progenitors. Now these are more lumpy and they look kind of like irregular shape, and often they resemble peanut shape, and they're like a little bit larger in size. And then we reach our stem cell derived beta cells. Now these are as you can see, this is like stage 6, day 10. So this is basically a little bit older. They appear more fluffy and like cotton balls, but this is how it should look like. And so this is the end stage. And you can see that there is a size difference between but the morphology and the germinal structure is the same. And then when we look over the 300 ml versus a 30 ml differentiation, we can see that the marker expression at all different stages are the same. So I'm going to just show you. So the 300 ml is basically the standard that people are doing and utilizing, especially in the Melton lab at Harvard. But we wanted to also compare both of them. So the 30 ml is kind of our test to see if we can achieve the same in the 30 ml format. So I'm going to show you some characterization data of the 30 ml. So here you can see the different stages written on top of the flow graphs and at different markers. And so you can see up on the first two left. So the unstained cells are in orange. The blue or the cyan is the secondary antibody control. And then you see the positive signal in the pinkish reddish color. And at different stages, at stage 5, we look for the markers that are associated at that stage. And in the bottom at stage 6, day 1, we see that we already have in the middle, you can see that there is a C-peptide positive cells and NKX 6.1 and C-peptide co-positive cells. And this is the C-peptide, as you might know, that is a byproduct of insulin processing. And if we take the same cells and go further, so you can see here, we get, again, this is stage 6, day 6 cells on the top, and the same cells at stage 6, day 19, 1 day after we perform the GSIS, which is the functional test. So at stage 6, day 18, we perform the functional test, which is shown on the right-hand side, and you can see that at 2.8 millimolar of glucose, the insulin response is low. So this is a low glucose, but as soon as we challenge it to a higher glucose response, they secrete insulin by themselves. And then as a second step of glucose test or glucose challenge with the 2.8 low and then high, and then we depolarize the membrane with KCl to release all their insulin content. So this is the ELISA. So basically what we can say or we can conclude is that we have successfully generated pancreatic beta cells from human pluripotent stem cells, and these were done in suspension in a 3D cultures. They expressed all the bona fide markers of beta cells, and they would respond to glucose challenges by secreting insulin in vitro. The next step is to transplant these cells into animal models. And as Alexandra mentioned, their lab is working on this novel encapsulation device. So we are putting both expertise together, and we'll just do this together with Alexandra's lab. Long-term goal is to transfer this protocol to a GMP setting. And the current limitations of the protocol that are out there that have been published, and even in the clinical trials, as Alexandra mentioned, with the ViaCyte or the Vertex, that these are very cell-specific protocols. So we have to come up with a protocol that is universal and applicable to all genetic backgrounds. And this is something which we are working on right now. Also, the functional maturity, which is the glucose response, insulin responsiveness to glucose, is also not very consistent. And so we are also working on something like this. And our long-term goal is to generate a 3D islet, which would have the correct ratios of different pancreatic endocrine cells, like some sort of like an islet organoid. Now, a perfect islet organoid is the long-term kind of a holy grail for us. So I'm going to leave you with the picture of Leonard Thompson. So we have come a long way from 100 years of the first insulin injection. And I think we are very close in getting a cure for type 1 diabetes, hopefully with the cellular therapies. So with this, I thank you for your attention.
Fantastic. Thank you very much indeed, Professor Sharia and Professor Alexandra. And I'm sure that is going to generate a lot of questions indeed in the question and answer session. So it's my great pleasure to introduce Professor Manaf Al-Qadani, who basically is the kind of major lead here in COVID research and has forged ahead with international recognition for the COVID work that's been done here in the Kingdom of Bahrain. And it's been a true pleasure to have the opportunity of working with Manaf with his drive and enthusiasm. Manaf, the floor is yours. Thank you.
Thank you very much, Professor Atkin. Well, congratulations to the Rcsi Bahrain team for this wonderful research efforts. I think everyone was saying when we're going to end talking about COVID-19. Unfortunately, we're not there yet. So in the next 20 minutes, if you go to the next slide, I thought we should just have some shed light on the current situation of Bahrain and what's going to be our next few months in terms of shifting from pandemic, hopefully into the endemic phase, and finally into the recovery. And the reason why I put recovery at the end, because we are not even reached the endemic when it comes for the worldwide. Unfortunately, before I go to the Bahrain data, and again, this slide is from 5 days ago, so I'm going to just give you some updates about the current figures. So currently, it's over 500 million of people suffered from at least one episode of COVID-19. More than 6 million of those people, unfortunately, lost their lives. And believe it or not, based on the WHO figures, and I think we are underestimating that because we have over 100 million of people who are still suffering from the long COVID complication. So 43% are actually suffering from non-COVID if you're not been hospitalized, and this is data comes from the University of Michigan. And if you've been hospitalized with severe illness, unfortunately, the risk of developing long COVID goes as high as 56%, and it is a multi-systemic complications. When it comes for our region, and again, I'm pretty sure we are really underestimating that figures. WHO last night on the media brief was stating in Asia, for example, 49% of our population are still suffering from the long COVID, and when it comes for Europe, it's around 44%, and I'm sure that might go high when it comes for the new sublineages, which is the BA2, which I'm going to talk about it in the next few slides. Again, before I go to the Bahrain data, just to give you some brief about the human coronavirus and if we are near to the end of this pandemic or not. So let's just give you some background about the coronavirus. So the first human coronavirus that infected human was back in 2002. We call it the SARS-CoV-1. I remember that because I was in Canada doing my fellowship training. This is when we had the SARS. Roughly around 700 people lost their lives worldwide. Then it ended in 2004. But in 2012, we had another human coronavirus, which affected mainly in Asia. We call it MERS-CoV, and Saudi Arabia was one of the most countries have been affected heavily, and it is now endemic until this date, and it has been reported again by the by the Saudi through the WHO office in Saudi Arabia that for every 9 people infected with MERS-CoV, 3 or 4 people would die. So it's quite significant when it comes for the mortality. And now we are on our 3rd year when it comes for SARS-CoV-2, which is known as COVID-19, and we have lost, as I said, more than 6 million people lost their life. We still don't know the origin of SARS-CoV. There has been some initiatives from the WHO. We know it comes from the bat, but we know that there's an intermediate host that can link between the human and the bat. And when it comes for the variants, I think that's the hot topic as well that I'm going to talk about it in the next few minutes. Unfortunately, coronavirus is very well known to mutate like any other respiratory viruses, but this is quite significant when it comes for coronavirus. So it gets the opportunity to survive by mutating, and this is the only way for the virus to survive. So if I tell you that today 56 of the developed countries are fully vaccinated, but nearly 14% to maybe 20% of the other risk countries, which is the 3rd world, are not vaccinated. So this is a nice niche for the coronavirus to keep mutating. So the Omicron is not going to be the last mutation you're going to hear. You're going to hear more of the mutation. The question is, do we have the tools to kind of keep the hospitalization and the mortality to the lowest level so that we can say we are into the endemic? And again, I'm going to spend time, what's the definition of the endemic? Bahrain-wise, those data comes from the Central Command Room, which is I'm a member with them. This is where I live now. So we are a member of 15 people. We work 24 hours. We provide all of this information for the decision making here in the Bahrain. We started that in January 2020, and we are still functioning from this. So this office is based on the training center in the BDF hospital. So as of today, 36 of the Bahrain population has been at least infected with the coronavirus. Today we have around 8,000 active cases with COVID-19. Luckily enough, 99.5% of those are living at or staying at her home. Only 5% being admitted to the facility. And again, luckily enough, with the high surge of Omicron, we only have 6 currently ICU. 3 of them are being intubated, and all of them are unvaccinated. And again, we're going to link a vaccine tool when it comes for the development of the variants. When it comes for the vaccine in Bahrain, 81% of the Bahraini population of the entire, we are 1.5 million. That's based on the latest record. 81% are fully vaccinated. And of those who are fully vaccinated, 84% have getting the additional dose, if you want to call it the booster dose. And 85% of those who are eligible have been getting the additional dose. We have over 1 million doses has been given as additional doses, and we have around 5,000 people who received the 4th dose, and we have a strict criteria, and that's for the immunocompromised or the most vulnerable. On the next slide, there are 4 major I think, achievement for Bahrain. Those are the one gonna be the key elements that we should continue working on them, whether we are in the pandemic or even in the endemic. Remember, when we say endemic, it means that you should have some tools, some monitoring and some surveillance to keep the radar and to keep reporting to the decision making about the situation of the country. So testing. So we started with the real-time PCR, we shifted into the antigen test, we did the serology, the seroprevalence when it comes for the antibody. Testing is the key things. We have done over 4 million of real-time PCR, and we have done more than 2 million of rapid antigen tests in the Kingdom of Bahrain. We have used it as a mobile unit as well. And another key element when it comes for combating and monitoring the situation is the treatment for coronavirus. And treatment is divided in two sectors. First, facilities. So we have dedicated initially 7,000 bed completely dedicated for COVID-19. Now we have around 560 beds, again dedicated for COVID-19. And the rationale is you want to separate COVID versus non-COVID. So you want to continue looking after even the non-COVID patient. And this is where we wanted to kind of separate the facility. And again, to prevent hospital-acquired infection. And that's what we learned from our colleagues in Saudi Arabia when it comes for MERS-CoV. Vaccine, again, that's the only way, unfortunately, that you can end the pandemic. There are two ways to get the herd immunity. Yes, by natural infection and by the vaccine. My question is, which one do you want to get? There's a risk of getting the infection by having the complication of the COVID, and even the risk of having severe COVID versus getting the immunity from the vaccine, which is actually put you at much lower risk of developing complication. How many people do we know that got, for example, heart disease from SARS-CoV? A lot in comparison to the vaccine, which is still reported to be a very rare side effect when it comes with the vaccine. If you live in Bahrain, I think everyone is aware of the Be Aware. This is a local designed application that can really tell you everything about COVID-19. I think every single individual in Bahrain knows about about the Be Aware. This is where you can get your result, secure an appointment for the vaccine, or even for the test. And again, tremendous really effort has been put into this application. And I think Bahrain was the first country in the GCC, because this is the information that I have and I can tell for sure, was the first country that they have used the electronic application when it comes for tracking and tracing COVID-19. On the next slide, we are still continuing doing the contact tracing, not to the extent level we used to do in the early of the pandemic, but until today we have reached over 900,000 of contact tracing, and you can say between 17 to 22% of those contact tracing they have reported to be positive. On the treatment, we used to have an inpatient protocol, and now we are shifting into the outpatient, which we're going to spend more time about the outpatient services that we are providing at Shamil. So I'm going to leave that. And on the next slide, I'm going to talk about the traffic light system. This is a very unique for Bahrain and even for the region, if not globally. So we have invented a system called the traffic light system. It's an alert traffic light system. The whole idea for people to be aware of the traffic light system is we wanted to shift or to engage the community now with us when it comes for containing the virus. And I'm going to say something very important. One of the ways that we have learned is to kind of contain the virus is to link the human behavior to the behavior of the virus. If we misbehave, the virus is going to misbehave as well. When I say misbehave, meaning that we're going to have more variant and more casualties. So initially we started this back in May 2021, where we have different color code system, and each color code system it's going to signify the rolling average of the new cases, and that was back then in May. Today, for example, we're using the rolling average for the number of people being admitted to the ICU. And again, this is one way we're going to shift from the pandemic into the endemic, and maybe very soon you're going to hear about the white zone, which is the recovery period before we reach into the normal life. So the basic idea of the traffic light system is everyone would know the exact situation of the Bahrain, and it's up to the level of the community to decide which level do you want. If you want to shift from green, which is I call it, it's the beautiful life for everyone, whether you're vaccinated or non-vaccinated. If you want to have a horrible life, which is the lockdown. Unfortunately, we never had the full lockdown here in Bahrain, which is the red color. So we need to reach up to more than 200 admitted ICU cases. And if you wonder why we have reached, why we have figured out the 200, this is based on our capacity, and this is based on our local data, which shows that we can really manage without having overburden or overflow of the health system in Bahrain by having 200 plus cases in our ICU, and we have 500 fully dedicated ICU beds only for COVID-19 in the Kingdom of Bahrain. So it's a nice way to kind of involve the community to know which level we are heading. And in certain situation where even we are in the green level based on our numbers, we elect to go, for example, into the yellow or the orange, and that was for a certain occasion. So, for example, if we have some certain occasion that we think that the level of engagement of the community going to be low, this is especially during the religious holiday, Ramadan sometimes, and that was back then in 2021. We had to go into the yellow or orange just to kind of contain the level of the virus. And even though if the number says that you should stay on the green. On the next slide, things that we're still doing, as I said, we're still meeting once a week. We used to with the decision maker. We used to meet every day. Now it's once a week where we report all the issues that we are facing and the clinical indicators. I'm happy to say Bahrain ranked as number 6 or 8 now worldwide when it comes for the level of the vaccination. But again, vaccination alone is not the only tool to kind of end this pandemic. When I go to the next slide, so people might ask, when you say 81% of the fully vaccinated, 81% of the entire population are fully vaccinated, what do you mean? Well, of course, we have not used the vaccine haphazardly. We have really used it very wisely, and we have really targeted into 3 phases. Initially, we wanted to reach our target, which is to go above 60% when it reached for vaccinating the elderly, and I'm happy to say we have vaccinated more than 90% now when it comes for the high risk group. And then we have shifted to the most mobile, less severe population, which is the younger generation, and we focus on those who are above age of 12, and we have reached more than 95% to be vaccinated. And of course, the other group, which will be the younger, if you are less than 11 years old, we have reached until today 13.7%. And I do understand there are some hesitancy and hiccups when it comes for vaccine those people, because parents would think those children would be at least risk, which is true, but they are not at zero risk. And unfortunately, luckily enough, not in Bahrain, in the US, more than 5,000 of kids have actually died from COVID-19. So COVID-19 cannot distinguish between whether you are old or young, but of course, if you are in the high risk group, the chance of having severe disease and then unfortunate death would be much higher. All right, next slide would be the most important slide. So on the next 3 slides, I'm going to compare the 3 variants in Bahrain when it comes for the new cases in comparison to the ICU cases in terms of hospitalization and then death. And even though, and I think if people are fully aware of this, Omicron, it's the most horrible when it comes for the transmissibility of the virus. And yet, even though we had reached the highest record, 8,000 of cases in one day in Bahrain back in February 10, if I remember correctly, we had 8,000 cases. In Delta, we reached up to 3,000 as a maximum daily reported cases. But if you go to the next slide, which is I think that's going to be the important one, when we compare the new daily cases in comparison to the active hospitalization, and this is where the vaccine would be important. Now, I know I have a slide to represent the slide versus the daily infection, but back in May 2021, when we had the Delta wave, the fully vaccinated people in Bahrain were roughly around 35%. In Alpha, which was January till March of 2021, the level of the fully vaccination was nearly close to 20%. However, what we noticed that the rate of hospitalization was much higher when it comes during Alpha and Delta. And when we had Omicron, and Omicron hit the door in December 5th, 2021, and we peaked in February when we had the highest record cases of Omicron, the level of hospitalization remained at the lowest. You're talking about 51, which is really nothing. And most of the 51 cases where 50% of them were non-COVID related, meaning they've been admitted for other reason, whether for knee surgery, whether they're admitted for a delivery or pregnancy, or just for other elective procedures. On the next slide, when it comes for the ICU, again, during the Omicron peak, which again, we scored the highest record, we had only maximum 8 cases when it comes for ICU. Now remember, the level of the vaccine here is different. Here we had more than 82%, plus additionally we have 85% of those who received the vaccine, they are fully protected. Yes, when we talked about this, of course, we will never forget about the natural acquired infection or the recovered COVID. This will add up to the herd immunity. So I can say in Bahrain, we reached 90% of our herd immunity collectively. On the next slide, mortality again was the lowest among Omicron, was the highest among the Delta, even though we say Omicron is a mild, but this is we have to say it in a careful note. Omicron is mild for those who are fully vaccinated. Omicron is not mild for those who are unvaccinated or non-boosted if you are among of the high risk group. On the next slide. Here we talked about a very interesting data reinfection. In Bahrain, we have done over 26,000 gene sequencing. This is based on 5 days record. And of those gene sequencing, we have actually identified 31,000 cases to be labeled as suspected or most likely to be reinfected, and we follow the WHO definition. So if the first episode of infection and you get this next episode more than 3 months, then you are most likely to have a reinfected episode. Or if the first episode was mild and the second episode was severe, or you're required to be hospitalized, again, this is most likely to be reinfected. But the most accurate definition, which is definite to be reinfected, is by gene sequencing. And we have done 676 cases confirmed to be reinfected. The highest amount of reinfection was actually in February and March. Thanks to Omicron. Omicron is very well known to be immune evasiveness, and even if you are vaccinated, you will get the infection, and that's very different being hospitalized. The majority of reinfection, if you're vaccinated, you're not being hospitalized. And unfortunately, we had some reinfection among the unvaccinated, which most likely you can get it within 12 days, and the chance of being hospitalized or getting severe illness on the second episode is much higher if you are unvaccinated. On the next slide, here just give you kind of a timeline of the reinfection. So the highest was reported in December and January, and of course now much higher in February. As I said, Omicron hit the door in Bahrain exactly on December the 5th. Initially we had the original Omicron, which is the 157.96, and then we had the BA1, and today we have the BA2, which is the most dominant strain. According to the WHO, 65 of the worldwide gene sequencing now is BA2, which is more transmissible than the original, and unfortunately it has extra 20 mutation at the top of the 60 mutation when it comes for the Omicron. So it's a hugely immune evasiveness strain. In the next slide, again, source of, I know I'm over the time, but I'm just going to go through it quickly. We're doing gene sequencing across many things, so traveler, critical cases, reinfection, and also in therapeutic like the monoclonal, which I'm going to spend time on it. On the next slide, this is the roadmap of the variants. If you go to the next slide, it shows you the, it's a very colorful slide, but you can see beautifully how Omicron replaced completely the Delta in less than 2.5 months. Quite impressive. Delta remained for almost 6 months in the Kingdom of Bahrain, and within less than exactly actually 12 weeks, we've been replaced by the Omicron, which is the BA1 and now BA2. All right, if you move on to the next slide, again, go to the next slide. I'm going to spend time on talking about the outpatient. If you just can move to the next slide, please. I'm going to talk about the outpatient treatment efforts. So next slide. So in Bahrain, we have introduced monoclonal antibodies back in August 2021. Initially was with bamlanivimab, then we shifted to the region COV. This is when we had the Delta and Alpha, but then when we, thanks to our gene sequencing, when we looked at our gene sequencing, and again, that's been confirmed even by the international data, those monoclonal were not effective against the Omicron. So this is where we had our sotrovimab. Sotrovimab is still effective, and it is one of the most wonderful. In Bahrain, they call it the magic injection because it actually reduced the chance of developing severe symptoms, hospitalization. And we have given for more than 6,000 people in the Kingdom of Bahrain. In the next slide, we have shifted. We are doing a small trial, pilot trial, where we're using off-label use. So it's meant to be used for those who are not hospitalized, but we have used now sotrovimab in over 100 people, the most vulnerable people that most likely they're going to go to ICU, and 78%, this is a very preliminary data, actually been discharged home. They did not require on oxygen, and those initially they had been at least on 6 liters of oxygen. A great result when it comes for sotrovimab. On the next slide, again, we had a very wonderful drug. Maybe people have started hearing about it. We started launching this program early February. This is the Pfizer pill called the Paxlovid. Again, wonderful. It reduced the viral load in within 48 hours. Again, we are doing a small pilot study. We have engaging 65 so far, and viral load went down quite dramatically. Yes, that's based on the CT value, which is again not the most accurate terminology for the viral load, but again, we lack in Bahrain, the full quantification of the virus. And the majority of those who receive Paxlovid, they stated that they don't have the problems, and we are really testing now the long COVID, whether they're going to develop long COVID or not. So far, none of them have persistent symptoms, but again, they have not reached the 3 months yet. So we're going to let you know about the efficacy of Paxlovid in reducing the long COVID complication. Now, the next few slides, I'm going to end up my presentation when we talk about the next step in the pandemic. Now, next slide. What have we learned here in Bahrain about COVID-19? As I said, clearly the behavior of the virus is completely linked to the behavior of the human being. Next, second is the testing. You need to use testing even if you are reaching the endemic, because without testing, without gene sequencing, you cannot provide reliable information to the decision maker, and you can fool them by saying we are out of the COVID. And unfortunately, that's what we are seeing across the globe when people felt that we are back to the normal and the cases started to go up. And unfortunately, you heard the cases in Hong Kong, in South Korea, when they had the zero tolerance on those countries. And once they have removed the mask and they want back to normal, unfortunately, they had the highest number of hospitalization and the highest number of death. Why? Because those populations, they have never exposed to the virus, even though they have not 90% have been vaccinated. But Omicron, as I said, it can easily escape your immune. Willingness to innovate and accept new ideas, and that's with the antigen test. Boy, I remember back in June 2020, when we introduced the antigen test, we had many scientists against the idea of using antigen tests. We use it in the school, in the social events, and then in the community. And over 2 million of tests. Antigen tests proven to be the the perfect public health tool when it comes for preventing spread of the virus. So this is completely different than real time. Real time, we use it for clinical decision making, for admission, for treatment, whereas antigen test was just to screen the population and to prevent the transmission. And finally, I mean, that's the most hot topic. How can you balance between the public safety, between the maintaining the education, the well-being of the human being, the economy, and maintaining the personal freedom? And that's a very difficult question, honestly, to be answered when it comes for the pandemic. Next slide. Again, COVID outbreak did and will still occur in the community. So we are expecting we might have some epi surge here in Bahrain if we misbehave again during, let's say, Ramadan. I know pandemic fatigue has been reached for everyone. I personally reached that stage a couple of months, but again, we have to kind of work together and we have to hold tight. Pandemic is not over, endemic is not being reached yet, so we need to work together to kind of fight this. On the next slide, I'm going to talk about the Bahrain multi-layer approach when it comes for combating. So this means testing, vaccination, and other thing, which I'm going to explain in the next, which is surveillance. So on the next slide, I think this would be things people would be more interested to hear about, is when we're going to shift from pandemic to endemic, where does one end and the other one begin? So I think once we reach into the seasonality driven wave, and I think that's what's close enough to be here in Bahrain, this is when we can say we are reaching the endemic. So that's what would depend on the behavior of the virus, the behavior of individual, the level of the transmission, the herd immunity, combination of natural and vaccine acquired immunity, and of course the severity. So if we remain at that level with Omicron, BA2, and we don't have a new variant, so no matter what cases you're going to have, this is going to be more just flu-like illness, because your hospitalization, and this is a predictive model that we have done, that if we remain at that level, we should be in the next few months into the endemicity before we go into the recovery. In the next slide, things to consider when it comes for pandemic to recovery, and this is where we're going to shift from endemic to into the recovery, is in Bahrain, we're working now on the long COVID complication. So we're trying to establish a clinics to look after the long COVID patient. I don't have the percentage of that yet because we still have not really collected the full data, but at least I think more than 2.5%, at least of those who have been reported to us, they still have more than 3 months of persistent symptoms. Healthy building, this is something we're working very closely with the top authority in the Kingdom of Bahrain. It's just basically how can we space out, how we can make more air ventilation better in the buildings, and I think that's the only way we can even handle if we have another emerging infection. Surveillance, now we are working on the waste water surveillance. It's an excellent tool, to be honest, and it's the most affordable to kind of predict if you're going to reach upcoming surge. I wish I have more time to talk about waste water surveillance, but this will really deserve a full-time presentation. And finally, I think once we reach 70%, General Director Tedros yesterday announced, if we reach in each country 70% of the population to be vaccinated, this is the time when we're going to say we are reaching into the endemic and then into the recovery. And finally, I'm very delighted to say in the next slide, we've worked very hard in the last 2 years, and we have produced over 31 publication, and out of the 31 publication, 20 publication comes from the Rcsi. So thank you very much, Rcsi, for all the efforts that we have put together. And all of this 31 publications, they have been converted into policy-driven data. And we have covered quite range of aspect of the virus when it comes from the transmission, viral dynamic, epidemiology, diagnostic, clinical treatment, and of course some guidance. And with this slide, I would like to end my presentation. Thank you very much.
Thank you very much. I'd like to now ask all of the presenters to be available for a number of questions that have come through from the attendees. Fergal, if I could turn to you first, there's a very interesting question here. The nerve growth that you actually have shown and stimulated, is it any particular type of nerve? So, for example, is it more myelinated rather than unmyelinated nerves?
Yeah, so a really good point, Steve. I guess one of the big learnings for us is that the Schwann cells, so the myelinating cells, are particularly important if you're trying to get restoration of normal function. And we designed the conduits with the neuronal cells in mind so that we could get neuronal axons to bridge the gap. But what we noticed was that if you didn't target the Schwann cells, if you didn't get effective Schwann cell recovery, you wouldn't get effective neuronal outgrowth as well. So I guess what I'm saying is the myelination piece is really important. If you want to get restoration of normal motor function, you need to get the Schwann cells in the right place. If you get the Schwann cells in the right place, if you've got the architecture, that helps them with axonal bridging and restoration of normal motor function.
That's great. And another question that came through, the microRNA that you antagonized, because they're very small, they're only 22 or 24 nucleic acids, would that affect other microRNAs and therefore have a kind of a wider effect, which could be detrimental as well as positive?
Yeah, I guess when you start working with microRNAs, one challenge with microRNA, two challenges with microRNAs. One, stability. They're very hard to manipulate, very hard to work with, because, to be honest, they normally they'll only work for a few hours or a few days. So we were really pleased to get our nanoparticle system to be able to control the expression of those microRNA, both mimics and inhibitors, for long durations, for up to days and weeks. So that was a positive. And I guess that was our primary concern, was could we get efficacy? So because safety wasn't an issue if we couldn't get them to work. But your point is very well made. With a lot of the microRNA targets, we're focusing on certain downstream effects that we know where they exist. But nonetheless, it is the case with many microRNAs that we don't know what other signaling pathways or what other downstream genes may be turned on if you're manipulating a specific microRNA. And I give you an example, which was a positive effect, was where we were targeting mesenchymal stem cells with microRNA 133A. And while it worked effectively with the MSCs, it also worked on macrophages, and that gave us a positive response and changed macrophages from an M1 pro-inflammatory state into an M2 pro-remodeling state. But maybe there are other effects that could be negative. So to try and screen that, we typically, in all those in vivo models, we typically would try to monitor off-target effects in the brain, lung, kidney, liver, to try and see where the particles end up and what to do. So far, there's no problems. And actually, one of the reasons why we don't think it's a problem is because you use the scaffold-based system, you're localizing where the microRNA is being delivered to, or the inhibitor is being delivered to, and therefore you don't have the issues that might occur if you were just delivering it systemically.
Sure. Rebecca, there's a couple of questions here, which firstly, did you detect any ethnic differences in the studies that you found, you looked at in your scoping review?
That's a really interesting question. Thanks, Steve. It was, I think I can say with confidence that in none of the studies we looked at did they actually put ethnicity as a characteristic in their sampling.
And another question is the relationship of activity to early knee replacement. Did you find that there was any evidence to suggest that apart from obesity, if people were active or inactive, did it make a difference and when they were going to get a knee replacement?
Again, good question. It didn't actually come up in these particular studies, and maybe it should well have done, is particularly in the one where we were looking at risk of needing knee replacement and at what age. But I can say that there's a body of evidence that suggests, particularly with loosening of the knee prosthesis, that if patients are heavier and active, it's a predictor of earlier loosening and if they're heavier and not active. But of course, we want them to be active.
Absolutely. Thanks for that. Alexandra, one question that's come through is, do we need pure beta cells, or does it need to be a mixture of cells to kind of perfect what needs to go back to treat type 1 diabetes?
Okay, well, that's an excellent question, and it's one that's the field has been working on and considering for a number of years now, because obviously, ideally, you would recreate an islet in its original state, as Shahryar alluded to earlier. You need those other cells types working together with the beta cells, ideally, but it's a much more complex differentiation to get to that point, and nobody has achieved it with excellence to date.
And another question that's come in is, why have other devices failed? What's the biggest problems that we've come across?
The biggest problem is the fibrotic reaction to any foreign body. Fibrosis basically strangles the blood supply, and without having a blood supply, the cell viability is completely gone inside any device.
Right, okay, thank you for that. Shahryar, there was a couple of questions that come through for you as well. You showed very elegantly how to produce your iPS cells. What's the success rate of producing beta cells?
Oh, can you please repeat that?
Sorry, so you showed very elegantly the process of producing a beta cell. What's the success rate of actually generating them? Is it 100% success all the time, or?
Well, as I mentioned, that it depends on the cell lines that we are dealing with. So once a protocol is established for a particular cell line, then it's almost like more than 90% that you can just repeat the same protocol on the same genetic background cell line, and then it is working pretty fine.
And how long does it take this entire procedure to produce a beta cell cluster from the stem cells? So
if we start with the stage 1, when we take our beta cells to the pluripotent stem cells, it takes around 20 days to reach beta cells, but then we need another 14 days for these beta cells to become more mature. So like all along around 34, 35 days.
Wow. Yeah. That's great, thank you. So Manaf, there's a question that's come through from Professor Al, and he's asking, in your view, a zero-COVID approach, as in countries such as China, New Zealand, and some parts of Australia, has proven to be incorrect and simply delayed a move to an endemic phase. What do you think of that?
All right, so this is just from my personal view when it comes for different approaches by the countries. So I'll just give you an example. So some countries have said that everyone should get infected, and we should develop the natural immunity, and that should be the way. And I think that also has been proven to be incorrect. And other countries have decided that we're going to look into the zero COVID cases, and they have done completely lockdown and closing the borders, and again that has been proven to be inaccurate. So it's kind of the answer going to be you have to manage in between, and you really have to first of all protect the most vulnerable. And when it comes for any pandemic, everyone will be you're not at zero risk. Someone will get infected. The question is, how can you minimize the collateral damages from this pandemic? And we are living in a very close world, to be honest. And this is one of the ideas. For example, Bahrain, we have never closed our borders when it comes for the port entry or even from the airport. And even some of the community has really criticized us for not closing the airport. But there's no scientific data that proven, and I quote this even from the WHO. And one of the papers that we worked with the WHO was about aviation, and closing the border actually has more harm than benefit. Lockdown, closing the border, it gives you just a temporary phase where you need to prepare yourself. As long as you have the tools and you prepare yourself, it's all about preparedness. Bahrain did it indifferently, that we really acted before the first case that we had. We prepared everything, and we established, for example, the command central room. And I think without having those data, feeding data to the decision maker, we could be like many other countries.
And there's another question that's come through saying, can you please explain a little bit more regarding the wastewater surveillance for COVID-19? But I'd ask you to be slightly brief on this one because you could talk a long time.
Right. So, for example, let's talk about Bahrain, since we have more data here about Bahrain, and I can talk behalf of other countries. So, for example, in Bahrain, the majority of the people, they just fed up from testing. We know there are some cases that they are positive, and they're not saying that we are positive. I know people personally that they are tested positive by the antigen, and they don't come for confirmation by the real-time PCR. Plus, it's the fatigue, Steve. So how can we have a reliable surveillance where we can say, are we coming down on the cases? Because when you reduce the number of the case testing, of course, you're going to have lower number of cases. So the best, again, if you go back to the history, is from the waste water surveillance, where in fact it's much cheaper. It's pooling all the sample, and you can detect not only for coronavirus, and this is something that we want to establish in Bahrain. We want to use it for other rotavirus, for example, and other pathogen. So the best way to kind of use it during the endemic phase, when it comes for the surveillance, in my opinion, is the wastewater surveillance.
Thank you very much for that. Fergal, there's another couple of questions for you. Firstly, neoangiogenesis is key. What stimulates that? Is it the actual matrix you're using, or is it just a natural progression of how cellular repair occurs?
A very good question. I guess angiogenesis is key in an awful lot of the tissues we do. Although in cartilage, sometimes we're trying to prevent angiogenesis because it can speed up osteoarthritis if we're not careful. The scaffolds are designed typically in such a way that they'll support vascularization. So you get an inflammatory response, you begin to get some vascular cells begin to penetrate it, because one concern would be that if we didn't design the scaffolds appropriately, if the pore size wasn't big enough, for example, you could inhibit vascularization. But for more severe situations, such as bigger, more traumatic defects, or areas where you've got typically impaired vascularization, diabetic foot ulcer being a really good example, that's where we need an additional pro-angiogenic stimulus, such as delivering a growth factor like vascular endothelial growth factor, or VEGF, or delivering a gene encoding for it. So it for complex indications, it becomes, we need something else. And I guess one of the most interesting things that we found from the nerve study, and I think our next generation, and I don't know if people follow this, but this week Integra Life Sciences launched their new Neurogen 3D nerve regeneration product. That incorporates Rcsi know-how. They license some of the technology from our lab, which goes into it, and that will heal bigger defects than was previously possible. And their job is to bring it to market. The next iteration of that, and the one that we're working on at the moment with Integra, is to have controlled degradation of the conjugate, so we don't get an influx of immune or vascular cells immediately. It's a delayed response, and because if all the vascular and immune cells come in together, it can inhibit healing. So I think the next generation for nerve and for other products perhaps is tailored vascularization when and where we need it, and that takes a little bit more engineering, but I think it's probably the future of where the field may go.
And a brief question, is the bone that's regenerated through the scaffold the same kind of quality as the bone that it's replacing, basically? Great
question. And in the initial stages, what we want to do is just fill up the defect with mineralized tissue, and reasonable quality mineralized tissue that will fill the gap and allow weight bearing, for example, if it's in a weight bearing area. It's the next stage, which should happen physiologically if we've got the first stage right, is that the natural native bone remodeling process will restore the quality of that bone to proper native bone. So I guess in the earliest stage, no, it's not the same quality. It's repair tissue, as you would get with a fractured callus in normal bone. But we need to make sure, or I guess if that works effectively, the next stage will lead to the high quality bone, and you should get normal functionality in time.
Great, thanks very much. Rebecca, there's a couple of questions come through for you. Is there a better method than BMI? Because BMI does not take into account consideration, that doesn't take fat into consideration.
Yeah, again, interesting question. There's a lot of literature out there that indicates that we shouldn't rely purely on BMI. We should, have adjuncts of girth measurements and other predictors and actual weight rather than just BMI and girth measurement. So I think in terms of looking at the quality of studies in the area, it's interesting that most of the studies did just look at BMI, which is a limitation because they should be looking at other anthropometric sort of measures and certainly girth and actual weight itself. Yeah.
And can scoping kind of review morph into a systematic review and then a meta-analysis?
Yeah, so it's become quite trendy now, if I can use that word, for people to do a scoping review and look at the landscape of the data to inform developing a systematic review protocol or proposal. So I've seen, and with a meta-analysis accompanying that as well. So sometimes a scoping review does the job on its own. It depends what your purpose is. But other times you might be using it as proprietary work to look at, structuring a systematic review protocol.
Thank you. Alexandra, there's a couple of questions here for you too. Can sporopollen be prepared to GMP standards?
Yes, they can, actually, because they're a highly cross-linked carotenoid material. They can be prepared that way. And obviously, that's a really important question when you're talking about use in humans in the future.
And has it been used in any other applications in humans? Because, I mean, if it's essentially immune inert, is what you're saying, then it may have great value elsewhere. Well, actually, interestingly, the answer again is yes. It has been used, and one particular use has been in topical formulations. And for instance, if you have an active chemical that is sensitive to UV light, it can be loaded into the exons and then applied topically and released onto the skin where it has maintained its activity. Wow, that's really interesting. Sharia, one of the kind of things that's just come through is if you're producing a lot of cells, can you actually freeze the beta cell clusters or progenitors for later use so that you're kind of, I'm sure they're very expensive to do, so can you actually freeze them down, then get them back up again?
Okay, short answer right now is not possible. Neither the clusters nor the progenitors can be frozen and then thawed back. So a lot of people are working on it, and also our lab is also looking into this, how to improve freezing. Yeah.
The other thing that you also suggested is that there was 2D and 3D cultures for the iPS cells. Do they have a preference? Do they prefer to have a solid substrate on which to kind of stick, or they're happy to kind of form spheroids in solution?
No, I mean, they don't have a preference, because once we grow them in 3D, we also look at their properties and their markers, protein expression markers of pluripotent stem cells, and they are almost similar to as they were grown on the 2D. So I mean, I don't think there is preference, but also there is a little bit we modify the media in a 3D versus a 2D, so that in 2D, of course, as you suggested, there's a substrate that they're sticking onto. But in 3D, there is no substrate. And then we are also not using any microcarriers. They are just self-aggregating to form these clusters. So there is a little bit of media formulation changes from 2D to 3D, but the rest of the stuff and the properties of the stem cell remain the same.
Fantastic, thanks. Maya, there's a couple of interesting questions here for you, my friend. Firstly, does Omicron give you long COVID?
So remember, to be labeled as long COVID, you should have persistent symptoms over 3 months. And I think we have not reached that stage yet, but I think all the variants, Omicron or non-Omicron, would have the same, because we are talking about the same virus, which is SARS-CoV-2.
And the new variants, I was seeing that more asymptomatic. So in other words, there's a lot of people still walking around with the virus, asymptomatic, and therefore spreading it.
Well, when it comes for the Omicron, for example, majority are symptomatic, but if you are fully vaccinated, you get this is mild symptoms. But unfortunately, if you are unvaccinated, when it comes for Omicron, you have the most severe. And one of the common symptomology when it comes for the Omicron, it's the fever and severe body ache, which again, in Alpha, we have seen more of GI manifestation. And headache, for example, when it comes for Delta. So it's a quite mix, but all the variants have the same symptoms. It might differ by 1 or 2.
And the final question is, do you think it's now safe to travel?
Well, as I said, as long as it's a risk assessment based decision, to be honest. This is what I do, for example, personally. If the country that I'm gonna go and travel has a very high risk of viral transmission, and access to medical care, for example, would be difficult, then this is where I decide not to travel to that country. So each individual has to take, their own risk assessment and decide.
Mark, thank you very much. And thank you very much to all our presenters. Fantastic presentations, great questions, fantastic answers. And thank you so much for participating. So Nevin, could I have the next slide, please? Great. So now we're on to the most high scored abstracts. And basically we had 72 abstracts that were submitted, of which the 6 most highly scored are here and to be presented to you. I'd just like to remind each of the presenters that you have 10 minutes, and at the end of which, and we're not going to have a question and answer session at the end. What will happen is that there will be 2 minutes of questions for each person, and then on to the next. Next slide, please. So I'd like to now invite Omar Abdulmalik to discuss whole exome mapping of genetic variants linked with the development of chronic recurrent multifocal osteomyelitis. Omar, the floor is yours.
Thank you. Good morning, everyone. My name is Omar, and today I'm going to present a study that I took part in Dublin, Ireland. This study is whole exome mapping of genetic variants linked with the development of chronic recurrent multifocal osteomyelitis, which I'll be calling from now on as CERMO. Next, please. So what exactly is CERMO? CERMO is a rare pediatric autoinflammatory disease that causes teral bone lesions. As you may know, osteomyelitis or bone inflammation is typically caused by bacterial pathogen. In this case, it's not. It's an autoimmune inflammation of the bone tissue that causes destruction. Some facts about CERMO: its worldwide annual incidence is 4 cases per 1 million, though the incidence is believed to be rising due to the awareness and better understanding of the disease. Age of onset is typically adulthood and childhood, with the mean age of 10 years old, and girls are typically more affected than boys with a ratio of 2 to 1. Next. So what does CERMO look in an MRI? We can see at image A, there is an inflammation at the right mandible and as well as soft tissue swelling. We can see at image E, there is inflammation, bilateral inflammation at both humerus, proximal humerus, as well as inflammation at the right ilium. We can imagine this pattern of inflammation in a 3 or 4 years old child and the devastating effect on his or her life. Next, please. While the exact trigger isn't completely understood, we believe there is a decrease in the regulatory IL-10 cytokine, which results in subsequently higher levels of pro-inflammatory cytokines such as IL-6, IL-1 beta, TNF-alpha, which overall results in osteoclast activation. So there is a bone inflammation and bone destruction. Next. Overall, SERMO is subdivided into syndromic forms such as Majeed syndrome and Dera syndrome with known autosomal recessive mutations, while the majority of SERMO cases are considered sporadic non-syndromic forms with no known genetic mutation. Next. So our objective is to investigate the whole exome or so-called protein coding area of our patients, SERMO patients, and to investigate allele variants with minor allele frequency of less than 1%. Would like then to calculate the counts for low impact variants and high impact variants, which will be used in future study, which is currently running. And we'll then compare the loss of function variance frequencies between the cases and the controls. So why did we focus specifically in this study on the loss of function variants, since these variants can individually alter the protein's functions and cause deleterious effects? Next, please. So we first gained ethics approval from the CHI at Temple Street and Cromlin at Dublin, Ireland. We then invited all children and adolescents below the age of 18 with confirmed SERMO. We then extracted DNA samples and performed whole exome sequencing on 43 DNA samples from the patients that accepted to take part of this study. Next, please. So the bioinformatic analysis, starting after receiving the whole exome sequencing data, we started with filtering out all of the variants that with poor read of depth, with read of depth below 20 and quality of depth below 2. We then functionally annotated all of the variants with effect prediction using the W&over website. Following this, we filtered out all variants with genomic quality below 20 and minor allele frequency of more than 1% in the non-Finnish European population using the Nomad website. We then generated counts for the low and high impact variants, which will be used as said in our next steps. Next, please. As for the loss of function variants, we individually inspected all of the variants that were present in 7% or more of our cases. And we called out all of the variants that were called incorrectly. We can see at the left top side, this light color represents one of the variants that we excluded from the data, as it turns out to be a pseudogene rather than a true gene. At the bottom left side, we can see one of the variants that we indeed included in our data. And as we can see here at the empty bar, this represents a frame shift deletion. Following this, we generated allele frequencies for the loss of function variants in the controls using the Nomad website for the non-Finnish European population. And then we did a basic statistical test to compare the frequencies between the cases and the controls. Next, please. As for our results, females represented nearly 74% of our cases, and the median age of onset was 9 years. And this is actually in line with other studies as well. Next, please. As for the filtration results, after filtering out all genomic variants with poor quality and filtering out all genomic variants with minor allele frequency of more than 1%, as well as synonymous variants, we've been left with 174 low impact variants and nearly 1,000 high impact variants. We can see at the right side the distribution of low impact and high impact variants across genes. As for the loss of function variants, we had nearly 400 variants after filtering out all of synonymous variants with minor allele frequency of less than 1%, more than 1%. Next slide, please. So for our loss of function variants, we had nearly 6 loss of function variants that were found to be statistically significant with a p-value of less than 0.001. 4 of them were found to be frame shift insertion, while 2 were found to be frame shift deletion. As we can see on the left side, given the RPKM level, which basically shows us the site of expression of these specific gene, we can see that 3 of them includes bone expression, while 3 did not include bone expression. Still, all of them were found to be statistically significant when we compared the frequencies between our cases and the controls. Next, please. So what's unique about our study? Most previous studies have looked into or did whole exome sequencing for variants with minor allele frequency of more than 1% and excluded the variants with minor allele frequency with less than 1%. In here, we inspected and recruited all of the variants that were present in our cases. We did not exclude any of the variants, and we indeed inspected the variants with minor allele frequency of less than 1%. Also, our cases cohort is likely representative of the Irish population, since we recruited individuals from the two main thermal management sites at Ireland. We also the loss of function variants, as I said, all found to be statistically significant when we compared the frequencies between the cases and the controls, and they could all be novel risk genes of developing the disease, since none of them have been previously described in the literature. Next, please. As with any study, we had limitation. Number one, we did not perform a trio analysis of unaffected parents for our cases, but we intend to do so if we repeated the study in the future. We also did not have the chance to perform a burden test, but we're currently doing it. We're currently at the stage of performing the burden test, which I'll be talking about in the next slide. Also, all four participants were of white Irish ethnicity, hence the results can't be generalized worldwide. Next, please. So our next actions is to choose a control cohort for the high impact and low impact variants from the UK Biobank, which we're currently doing. We'll then use the RVX caliber method to calibrate the differences and the sequencing methods between the cases and the controls, and we'll then do the burden test. The burden test is basically a test that collapses all of the variants within a given gene element, such as a gene sequence or functional few genes. This will give us a better statistical tests. Following this, we'll do conformational sequencing, user Sanger sequencing, to make sure that we got the right sequences for the high risk and low risk variants. And finally, we'll do functional studies on true cells to predict the effects of these variants on cell function. Next slide. Finally, I'd like to thank Dr. Diary O'Leary, the principal investigator and my supervisor in this research, as well as Professor Jerry Wilson and the Conway Institute for hosting me. And next slide, here are the references, and thank you very much.
Thank you very much indeed, Omar, for your very clear presentation. So the loss of function kind of genes that you actually found, was that universal in all the samples, or was there subtypes where you didn't find those loss of function?
Yeah, so as mentioned, we looked into loss of function variants that were present in 7% or more of the population, which represents, which is nearly 3 cases per 43 of our cases.
And how much of the actual disease is due to kind of Mendelian hereditability? Or
it's a really minor percentage. It represents around, I would say, 5 to 10% of thermal cases. So still, most of thermal cases are considered sporadic non-syndromic forms with no known risk gene as of now.
So really, most of the kind of is due to kind of rare variants.
Exactly.
Contributing. And did you find, I mean, I presume that what you also had are siblings as well, or were there just sporadic cases within families?
We had siblings, but we excluded the data from our cases, since genetic variants can be found in siblings more than the general population.
Absolutely.
So we are individually inspecting them.
That's great. Thank you very much indeed, Omar. An excellent presentation. So turning now to our second presentation, and that is done by Dr. Hajar Abdullah. Surgeon performed point-of-care ultrasound in the diagnosis of acute sigmoid diverticulitis, a pragmatic prospective multi-center cohort study. Dr. Hajar, the floor is yours.
Thank you very much, Professor. So can I have the next slide, please? So the main point of our research, my colleagues and I have written, focuses on sigmoid diverticulitis and also the use of ultrasound, particularly the point-of-care ultrasound scan. So we chose sigmoid diverticulitis because it is one of the most prevalent disorders that present under surgical practice in the emergency department. Sigmoid diverticulitis is also associated with higher levels of complications in the form of abscesses, perforations, and peritonitis and sepsis as well. So in order to prevent these complications, it is essential to establish an early diagnosis and also classifying the severity of the diverticulitis. In current practice, CT scans are the gold standard gold standard diagnostic imaging modality. However, as many of us know in clinical practice, in large centers with resource constraints, it can be particularly difficult to get a CT scan in a timely manner. Next slide. And so if you have a delay in getting the diagnosis, this will delay the commencement of appropriate treatment in acute diverticulitis, hence affecting patient morbidity, the length of stay in hospital, and also the overall healthcare costs. Next slide. So in current practice, portable ultrasound machines are used in the emergency department for various different anomalies and procedures. They're used to establish arterial or venous access, central lines, and also used in trauma patients to exclude intra-abdominal hemorrhages, as well as for obstetric fetal assessments. However, unfortunately, to date, the uptake of point-of-care ultrasounds by surgeons to diagnose abdominal emergencies has been very limited. Next slide. So our study, following a literature review, looked at the accuracy, the sensitivity, and specificity of ultrasounds in diagnosing abdominal pathologies, particularly acute sigmoid diverticulitis. And we wanted to establish if it could be used as a first-line imaging modality as opposed to using a CT scan. Another aim of our study was to determine the duration between the point-of-care ultrasound scan being done versus getting the final CT report by the radiologist. Next slide. So the methods, the study was conducted in 4 centers in Italy, Portugal, and Ireland over the last 4 years. The patients that fit the inclusion criteria that presented to the emergency department had an ultrasound scan done by a point-of-care ultrasound certified surgeon. And if the ultrasound findings were positive, the patients would have then been admitted for a CT scan assessment or for surgery. If they were not positive, then they would have been discharged. Next slide. So these are the inclusion and exclusion criteria. The inclusion criteria included any clinical signs and symptoms of acute diverticulitis, as well as laboratory findings, such as elevated white blood cell count and elevated C-reactive protein. Our exclusion criteria, as listed in the slide, shows that we excluded under 18 patients, pregnant women, as well as obesity, because there is a limited ability of ultrasound scans to penetrate through the high density fat, therefore limiting the visibility of any abdominal pathology. We also excluded patients who had acute diverticulitis within the last 2 months, but presented to the emergency department for non-critical presentation. And we excluded patients who had a colonic resection. Next slide. So a positive POCUS scan is defined as having a bowel wall thickness of equal to or greater than 4 millimeters, having pain on graded compression, having evidence of pericolic fat changes in the form of increased echogenicity, and also the presence of diverticulae. The presence of complications in the form of abscesses, free fluid was also identified through the POCUS scan and classified using the modified Hinchey classification system, as you can see on the right bottom of the slide. Our primary diagnoses were then stratified into uncomplicated diverticulitis, complicated diverticulitis, and other diagnoses. Next slide, please. So the results of our study can be seen in the next slide. Our first is the demographic data. So we had a total of 45 patients in our study. And of the 45, 97.7% were admitted. Only 1 patient was discharged. Next, please. And of the findings using the ultrasound scan, the most common findings were pericolic changes, pain on graded compression, and bowel wall thickness of greater than 4 millimeters. Only 55.5% of our patients had visible diverticulae at the time of the scan. Next slide, please. And in terms of the classification of severity, well, 82.2% of our patients were defined as being uncomplicated diverticulitis, meaning they had either Hinchey 0 or 1A, and only 8.8% had complicated diverticulitis, meaning 1B and above. Though in our patient study, we only had patients who were classified as being 1B. There were 8.8% of patients that had other diagnoses that were not acute diverticulitis that was found on the ultrasound scan. Next slide, please. So the sensitivity of the ultrasound scan in our study was shown to be 100%. It detected every single acute sigmoid diverticulitis in our patients, though the specificity was 44.4%. And using CT scan as the reference standard, the point of care ultrasound had an overall accuracy of 88.8%. There was no statistical difference or significant difference between the CT scan and the point of care ultrasound scan reported findings. And our Cohen's kappa coefficient was calculated to be 0.56, meaning that there was a moderate agreement between the radiology report, the CT report, and the point of care ultrasound scan regarding the overall diagnosis. Next slide, please. And the average interval between the ultrasound scan and the formal CT scan was an average of 9.14 hours, and it ranged up to 43.5 hours. Next slide, please. So what are the benefits of the point of care ultrasound scan? Well, it gives us an earlier diagnosis of acute diverticulitis and also helps us assess the severity of the diverticulitis, leading to a timely approach or a timely management of these patients. These devices are small, are cheap, and are portable, and they can be connected to a mobile device, a laptop, instead of having to carry all of the equipment around the hospital. It is invaluable in situations or in settings or areas in the world where there are limitations to formal radiology, like CT scans. Of course, also avoiding radiation exposure and also reducing costs. Next slide, please. So there are some discussion points that some individuals might come up with, saying that, well, patients might need a CT scan anyway. Well, that might be a case to argue. That does not defeat the purpose of the ultrasound scan. Our purpose is to have an earlier diagnosis, and it has been shown to be accurate, therefore allowing us to initiate treatment without delay. Another argument is that many patients who are critical and have acute diverticulitis will present so, and there might be no need to get an ultrasound or a CT scan. Well, we do not want to leave things up to chance, as it has been shown that one surgeon was criminally charged with manslaughter following a patient that unfortunately passed away because there was a delay in the CT scan, therefore delaying appropriate management and surgery. Next slide, please. So the limitations of our study, basically the role of CT scan that we used as a reference point for point of care ultrasound could be argued as a limitation because CT scans in themselves have false positives and false negatives. So ideally we would have used another reference point such as intraoperative findings. Our sample size also was limited because of the fact that there were a limited number of surgeons certified to perform the point of care ultrasound scan in each of the study centers. And another limitation, as I mentioned earlier, is that we excluded obese patients from the study population, and that was because of the limitation of ultrasound in penetrating that tissue. So, and obesity is a known risk factor for diverticulitis, and hence in future studies, we would have liked to investigate that further. Next slide, please. So in conclusion, our study has shown that point of care ultrasound, it's fast, it's effective and accurate in diagnosing and staging acute diverticulitis. Hence management can be commenced earlier and preventing complications from arising. It avoids unnecessary radiation exposure and as well reducing hospital costs, and is essential in areas of the world where there are limitations to access to formal radiology. And the outcomes of our study do reflect a real-world scenario in which scans can be performed by consultants or experienced surgeons on call. Next slide, please. These are my references. And next slide. And these are the authors, and I'd like to acknowledge in particular Professor Thomas Walsh has been a great help and aid in writing this paper. And I'd like to thank also the primary investigator, Dr. Bogdan Daniel Dimbrava. Thank you very much.
Thank you very much indeed, Dr. Hoja. You mentioned that BMI was an issue because BMI over 30 was excluded. Did you notice any difference in sensitivity if you kind of compared a BMI over normal BMI of say 19 to 25 versus those who have a BMI of say 26 to 30 who would be classed as overweight?
So in our study, we didn't really focus on the differences in the ultrasound findings of patients below of normal BMI and above 26 to 30 BMI. But of course, the sensitivity would have been slightly limited, but it is a point for further studies in the future.
And of course, one of the problems with ultrasound, as Saul said, is it's more operator dependent.
Definitely.
And so you said there was 4 centers. Did you notice any difference between the 4 centers that might reflect, the operator?
Well, in terms of the operators, they all attended a point-of-care ultrasound certification program. They were highly trained surgeons who not only attended the program, but they helped run the program as well. So in terms of differences in operator management or imaging, of course, there is the likelihood of human error. However, what is important in our study was shown that the sensitivity or the ability to identify the acute diverticulitis or exclude it has been very high. And so if for future purposes and future training, we'd like more surgeons to go through this course, and this will definitely help out in the emergency setting in the surgical practice.
And I don't know if it's possible for you to answer this, but is it also ultrasound probe dependent? Because there's different types of ultrasound probe, aren't there?
Yeah, definitely. So you would have the different probes ranging from the flat probes to the curved probes and all of the different types of probes. They definitely have a difference. And also the different devices that are being currently sold on the market. I'm not so sure if all of the surgeons in the 4 different regions had the same devices. However, it is a very, very important point to note, especially in future researches on this topic, definitely.
Great, Dr. Hoja, thank you very much indeed. Very nice presentation.
Thank you.
Can I have the next slide, please? Right, I'd now like to invite Dr. Reem Al-Ansari to present Bad News Better, Learning Breaking Bad News During the Time of a Pandemic, a Mixed Method Study. Dr. Reem, the floor is yours.
Thank you very much. Good morning, everyone. My name is Reem Al-Ansari. I am a radiologist. I completed my master's in medical education and my fellowship in clinical simulation at Harvard Medical School. I'm currently a PhD candidate in health professions education. I'm a medical educator and I do med ed research and simulation-based education at the Arabian Gulf University, and I'm an instructor at Harvard Medical School. I want to first thank the RCSI for this kind invitation, and then I want everyone to take a step back and think about Dr. Sarah. Sarah is a newly graduate. She started her internship a week ago, and during her first week, she had to tell a sick patient that he tested positive for COVID-19. Sarah asked herself, am I ready to do this? Am I confident? Are confidence and competence the same things? And what is the worst that can happen if I don't do this well? So Sarah is a fictional character, but just like Sarah, many junior doctors around the world had to convey bad news to patients very early in their careers as a result of this pandemic. Next slide, please. So this study aims to answer all those questions at a time where the pandemic affected the medical education landscape in 2 ways. First, due to the pressure on the healthcare systems, many junior doctors joined the fight against COVID-19, where part of their responsibilities was to break bad news early in their careers without a lot of worldly experience. Second, as the pandemic presented practical concerns for patient and student safety, senior medical students' time in the hospitals for clinical rotation placements in the wards has significantly decreased, and their time in front of their computers learning online increased. Next slide, please. So the challenge that medical educators all around the world were faced with was to provide these students with authentic patient experiences under these circumstances. So while delivering COVID results and other bad news is something every healthcare professional must do in person or via telecommunication, practical training for that poses a set of ethical challenges. You can't really practice on real patients, and that will expose these junior doctors to unnecessary emotional harm as well. So for that reason, simulation and the use of standardized patients are widely used. But for breaking bad news specifically, SIM has recognized challenges like overestimation of confidence over actual performance and the acceptance of SIM as a replacement for real patient encounters. Many of the practices that we've developed during the pandemic are likely to remain even after it's gone. And this study describes the development of a remotely deliverable or SIM-based or telesim-based breaking bad news learning intervention for senior medical students in Bahrain and reports on its impact. Next slide, please. So to develop our project, we employed Kern's framework for curriculum development for med-ed. And through our needs assessment, we had confirmation that an educational intervention was needed right away. It included one virtual 3-hour small group session that we ran 8 times. It was called the Bad News or the BNB, Bad News Better Workshop. It started and ended with an OSCE where students had to disclose sensitive and bad news to standardized patients. Next slide, please. And the impact was assessed using 5 complementary outcome measures. We measured pre and post confidence, subjective and objective skills, and we realized that breaking bad news is a challenging task that involves dealing with intense emotional content. So we also collected students' responses on their psychological reaction to the session. And finally, we collected a lot of data on the learning experience as well. Next slide, please. So through our quantitative results, we had our demographic data. We had mostly students from Bahrain, some students from Saudi Arabia, and some students from Kuwait. Next slide, please. Most participants had never observed or participated in role-play scenarios with standardized patients that truly equipped them to break bad news, and they've never directly observed clinicians break bad news to patients at this time. Next slide, please. So the students' level of confidence in specific components according to the SPIKES protocol, which is the tool we used for training, showed statistically significant improvement from pre to post on all components. Next slide, please. And the level of confidence allowed how prepared they are, how confident they are in their skill level, how overall confidence they have to break bad news, and the improvement in their level of anxiety related to breaking bad news all improved from pre to post with large effect sizes. Next slide, please. So when it came to skill development, according to the SPIKES protocol, we found improvement with large effect sizes in communication skills in all but one item, according to the students, which is the use of clear and lay terms and not medical jargon. I can talk about that later if you'd like. And then objectively, as rated by expert standardized patients, that we saw improvement with large effect sizes in all communication skills along all domains. Next slide, please. So we employed Russell's circumplex model of affect, which is a tool with known validity and used to measure affect during learning. We use it a lot during SIM, and we correlated all of our results and all our variants to try to find a relationship between emotional activation and learning. We had a little over 200 correlations that we ran. Next slide, please. Participants highly rated the session, provided them with a positive and safe learning environment. It contained relative and culturally appropriate content, which was very important for us. And they all said that it should continue as part of their training curriculum. And it was no surprise that they found that the role play or deliberate practice portion of the workshop to be the most useful component. Next slide, please. So through our qualitative analysis, which we interviewed 10 students in semi-structured in-depth interviews that ranged about 45 minutes to 1 hour, we found 4 themes. The first one was that they experienced a range of emotions. Negative emotions like feeling tense and helpless were expressed at the start of the learning experience, where they had to deliver bad news in the beginning of the workshop. And these initial negative feelings gave way to positive emotions like excitement related to the acquisition of new skill and knowledge, and to the learning method itself, which was highly interactive. Next slide, please. A comfortable learning atmosphere seemed to have particular salience for small groups, and the importance of learning by doing in the form of deliberate practice and the concept of productive failure and learning from mistakes was a pivotal point in the learning experience. Next slide, please. Participants explained that their experience was highly intrinsically self-motivated, and being the assessors of their own learning really put them in the driving seat, and that was very valuable. Next slide, please. Our final theme was that having tangible, witnessable results that the students immediately felt when they ended the workshop, like that baseline performance score through the pre-test, that was a real driving force that pushed them to apply themselves and perform better. And as a bonus, the group work and unique learning atmosphere fostered learner collegiality, and they formed new friendships and new study groups as a result of the positive interaction. Next slide, please. So this was our joint display between our qualitative and our quantitative results, but the most important thing is that little circle in the center. Next slide, please. So when it came to skill and confidence, the qualitative data confirmed the findings that we found in the quantitative phase. They learned, they developed their skill and their confidence. And the qualitative data expanded and explained the learning experience quantitative results more deeply. We could not find any meaningful correlations between learning and emotional activation quantitatively, despite using a tool with known validity and despite running a lot of correlations. And that was a bit frustrating because that was the opposite of what we found qualitatively. Next slide, please. So the improvement in performance seen by expert standardized patients that rate Breaking Bad News skills, not by merely documenting whether each task was ticked off by done or not, but by the quality of which they were performed, provides objective evidence of the real impact of this program. Our findings aligned well with Malcolm Knowles' 4 principles of andragogy, and we found that the common factor between our results and adult learning theory was psychological safety. Psychological safety is a precursor for learning-oriented behavior, like asking questions, asking for help, and learning from mistake. And we found that that is the foundation of experiential learning and problem solving. So the discordance between our inability to quantify the relationship of emotional activation to learning and our ability to identify how students' emotions and feelings had such a significant impact on learning qualitatively was super important. And we attribute this discordance to the beetle in the box analogy, which is widely known in medical education, which states that unlike knowledge and skill, the private experiences of medical students are beetles in boxes that cannot be objectively measured. And the attempt to quantify affect during learning risks causing complex concepts of emotions to lose their essence, and that exploring the student's emotional activation in response to learning in a space that allows them to reflect, explore, and talk is a more acceptable and effective method. Next slide, please. So we found our model to be an efficient way to teach medical students how to break bad news in the virtual space, and it showed a significant increase in their skill and confidence. We gained great and new insight about how emotional activation affected psychological safety, which impacted learning. And most importantly, this workshop offers a format that is adaptable to numerous critical conversations, not just breaking bad news, and can be applied to a variety of disciplines. Next slide, please. So we have a lot of ideas to do in the future for future research. We want to replicate the workshop with more communication skills, have a larger sample size. We want to include patient outcomes. We really want to find out that sweet spot of retention and durability of learning. When do students keep that learning? And we want to do further work into the validity of quantifying emotional activation. But most importantly, the evaluation data from this work that took 2 years will really assist in fine-tuning the content and format of the future of telesim-based communication curriculum development. Thank you very much.
Thank you very much indeed, Dr. Reem. That was excellent. A lovely presentation. So I suppose the first question is, did you tailor this with different ethnicities? So in other words, do different ethnicities have different problems or respond the same way?
So that is a great question. And because I wanted to really anchor this in our context of Bahrain, and we utilized Kern's framework, we wanted to keep this intervention extremely culturally appropriate. Breaking bad news in the Middle Eastern culture is unique and requires specific training. So we did anchor it in our specific content, but a lot of the results that we found really translates into, so this was an AGU and Harvard Medical School collaboration. And a lot of this really translates into any learner. That answers your question.
It does, and it partially answers the second question as well, because obviously you had a standard approach, and did you have to tailor it to the kind of personality of the individual or the student?
That is a great question. So what we did, something I did not add in the presentation, we also had a sixth outcome measure, which we tested the personalities of all the students, and we wanted to examine those results. And that is a future study that we're going to do. We are going to correlate the personality test results of the students to their skill development, confidence development, and emotional activation. But we did pilot everything. And when we piloted the study or the intervention with a smaller group of sample, we used all of that input to make the intervention more culturally relevant, to suit the personalities of the students in Bahrain.
And one of the things that you did mention in your presentation was that there was a degree of anxiety in some students, and that, you know, that was one thing that improved with the workshop. Were there any students that actually just didn't get over their anxiety?
So we did not have any students that reported zero improvement in their anxiety, but through the qualitative component, we found out that some of the students reported good anxiety or good stress. And if we learned anything from the cognitive science of learning and harnessing the power of neuroplasticity, some emotions like positive stress can actually help learning and help students recall the information when they need it.
Fantastic. Thank you very much indeed, Dr. Reem. Excellent presentation. Thank you. Next slide, please. So now I'd like to request Dr. Priti Board, a postdoctoral researcher here at RCSI, to present on the sigma-1 receptor, a potential prognostic biomarker and component of the cellular stress response in breast cancer. Priti, the floor is yours.
Good morning. Thank you all for being here. Today I will be summarizing key findings from our research into the significance of the sigma-1 receptor in breast cancer. So breast cancer is a heterogeneous disease. Patients with ER-positive tumors can receive systemic therapies like tamoxifen, while HER2-positive tumors can be treated with HER2 blockers. No targeted therapies are yet available for triple-negative breast cancer, which, as the name suggests, does not express any of the standard targets. Patients with triple-negative tumors have shorter survival times and are at higher risk of metastases. Chemotherapy remains the main option for treatment in the neoadjuvant as well as adjuvant settings. While hormone and HER2 receptors are enduring prognostic markers, there are no reliable markers for tumors which do not express these two. So a bit of background on the functionality of the sigma-1 receptor. It is a known modulator of the cellular stress response. Under basal conditions, sigma-1 remains bound to BIP, which is the key stress-activated chaperone at the endoplasmic reticulum. In stressed cells, BIP releases sigma-1 to initiate the cytoprotective unfolded protein response, or UPR. Unbound sigma-1 then stabilizes various proteins across the cell. Cancer cells are known to be overly dependent on the UPR for survival, but there has been very little study of sigma-1 antagonist-mediated signaling or investigation of its potential as a prognostic biomarker for breast cancer. So to begin our investigation, we first analyzed sigma-1 gene expression in a number of publicly available patient datasets. These are paired comparisons between non-cancerous and cancerous samples from the Cancer Genome Atlas, and there was twofold or higher expression of sigma-1 in the triple-negative tumors compared to their matched normal tissue. We next looked at gene expression between the primary tumors themselves and saw that triple-negative samples express significantly higher levels compared to other subtypes. We observed the same trend in two additional cohorts, the SMC and Metabric. We next evaluated whether this elevated sigma-1 expression had any correlations with actual patient outcomes. And in two different cohorts, we saw that primary tumors which relapsed had higher sigma-1 expression compared to those which did not. These are results from the Metabric cohort, which is a large data set with long patient follow-up. And we found that in the ER-negative, HER2-negative group, high sigma-1 correlated with poorer outcomes across the board. So from left to right, these are survival curves for disease-specific survival, as well as distant metastases and local recurrence. We did not see similar results in other clinical subtypes that were examined. So we next wanted to look at sigma-1 protein expression, and we stained a tissue microarray over at Beaumont Hospital in Dublin. These are associations between sigma-1 positivity and tumor characteristics. Among other things, we noted an inverse relationship between ER and PR positive status. We then looked at survival analysis, and there was a significant correlation between high sigma-1 expression and poor prognosis, a relation which, in nice agreement with our gene analysis, resolved into the ER-negative, HER2-negative group. So you can see that there is good separation in the triple-negative group as well, but this didn't reach the threshold for significance. In multivariate analysis, sigma-1 was not found to be an independent prognostic factor in any of the examined subtypes. So coming now to some of our in vitro work, We evaluated sigma-1 expression across a panel of 9 breast cancer cell lines, and we found that in broad agreement with previous findings, sigma-1 is present at relatively low levels in most ER-positive models. So on the left, you can see MCF7s, which are kind of the classic ER-positive endocrine treatment-sensitive model. LY2s are tamoxifen-resistant cell line, which has been derived from MCF7s. And over on the extreme right are 2 MDA cell lines, which are triple negative. And you can see they express fairly high levels of sigma-1. So we then looked at the effects of treatment with a sigma-1 antagonist called IPAG on the unfolded protein response, which, as I mentioned earlier, is a key set of stress response pathways. So we treated selected cell lines with IPAG and tracked the expression of key proteins by Western blotting, immunofluorescence, and also did some cell viability assays. So I'll talk first a bit about our results in LY2s. We found that exposure to IPAG caused sigma-1 to aggregate into distinct patterns across the cell. So this is a higher magnification image that maybe shows this more clearly. And you can see after 3 hours of treatment, these clumping or aggregates of sigma-1 close to the nucleus. This is an overlay with BIP. Sorry. And you can see that there is co-staining of these 2 proteins in the treated cells, which was not visible in our vehicle-treated cells. We found that signs of UPR activation by Western blotting, including appearance of XPPS1 and ATF4, which is 2 of 3 key transcription factors generated by early protective UPR, were visible within a few hours of IPAG exposure. Prolonged treatment, so post 6 hours, and you can see large increase in BIP, which again is the major stress-activated chaperone. So this makes sense. This is a sign of cells that are not able to resolve the stress that is being placed upon them. So the increase in chaperones points to an increase needed for protein folding within the cell. We saw loss of viability by MTS assays from about 48 hours onwards, which is in agreement with several previous studies, which shows that prolonged exposure is needed to trigger cell death. So these are the Western blot results from LY2s. We saw similar results in MCF7s, and these are the triple negative MDA468s as well. So you can see spiking of transcription factors early on, and then increases in BIP. So to summarize, sigma-1 is differentially expressed across breast cancer subtypes. Triple negative tumors tend to show higher expression levels, and there's a subset of patients with high sigma-1 which tend to have shorter survival times and are at higher risk for relapse as well. Exposure to IPAG induces sigma-1 to aggregate and also triggers the UPR. And there are several standard methods of breast cancer treatment which also seem to work through activation or overwhelming of the UPR in cancer cells. So we're very interested to know how sigma-1 ties in with these standard treatments. These are very preliminary results from what from the research that's happening right now. So we're looking at associations between sigma-1 expression and responses to chemotherapy. This cohort is treated with neoadjuvant therapy, and you can see that in triple negative patients, those that achieved pathologic complete response had higher levels of sigma-1. It's a fairly small number of patients, so we're looking to increase this cohort. And we also have a collaboration currently with King Hamad University Hospital, where we're looking at mutations and changes in expressions of these receptors in triple negative breast cancer patients. So I'd like to acknowledge especially all the people over at Rcsi Dublin and Beaumont Hospital in Dublin, and of course the principal investigators and the Dillman Scholarship Program in particular.
Rcsi, thank you very much indeed. That was a very nice presentation. Can I have the next slide, please, Nevin? I'd now like to call upon Renat Hesham Al-Ansari to present protein-assisted synthesis of silver nanoparticles for biomedical applications. Renat, the floor is yours.
Thank you, Professor Stefan. Good morning, everybody. My name is Renat Al-Ansari, and I'm a foundation year medical student at Rcsi Bahrain. First of all, I'd like to say that it gives me a great pleasure to be here with everyone here today, and I would like to thank the organizing committee for giving me this opportunity to present our research at this conference. So today I'll be presenting our research titled Protein-Assisted Synthesis of Silver Nanoparticles for Biomedical Applications, and I'll be presenting some of our preliminary results that we have gained throughout this project for the past 4 to 5 weeks. Can I have the next slide, please? So nanotechnology forms a very vital pillar in translational research. And what I mean by translational research is we take any results that we have gained in the lab and we convert it into something that can be clinically beneficial to patients. So nanotechnology is basically the science of producing materials of nanometer length. These can be things like nanotubes, nanowires, nanosheets, and what we focused on, nanoparticles. And for a particle to be considered as a nanoparticle, it has to have a size within the range of 1 nanometer to 100 nanometers. These materials can actually be produced in a variety of different methods, some of them being physical, chemical, and biological, but the physical and chemical methods do have their disadvantages related to toxicity, and these are quite risky because, as we know in the medical field, toxicity can't be tolerated by patients. So in this regard, biological methods use things like plant extracts, proteins, and plants. And these are gaining importance as these materials abolish the toxicity-related issue and provide us with stable particles. The size of the nanoparticles produced is very important, and they form a surface decoration and they're important because of the medical applications in cancer therapy and cancer diagnosis, because they have to be really specific. So in this project, we use nanoparticles because they were safer than any other materials, and they're safer than any other methods like surgeries, photodynamic therapy, and others. They eliminate any side effects, and we coated our silver nanoparticles with a safer material, which was the bovine serum albumin protein. Now, the question you might have is, why did we use the BSA protein? Why did we not use any other protein? So can I have the next slide, please? So BSA actually has a molar mass of around 66 kilodaltons, and that's important. I'll come back to it later. It has 582 amino acid units, of which the majority are serine and threonine units, and it has mild reducing groups on its surface. So the molar mass is a very important factor because as we have a greater molar mass, we have a higher number of the hydroxyl reducing groups. And the role of this hydroxyl reducing group is to reduce the silver ion to silver nanoparticles. So on the left-hand side, you can see a schematic of our procedure. So we added 1 millimolar of silver nitrate and 3.7 times 10 to the minus 5 of BSA. We shook the tube for 10 seconds, and then we added half molar of sodium hydroxide. And then we observed the first indication we got, which was a very distinctive color change. So in the images in the center of the slide, you'll see we have 3 tubes, which are colorless solutions, and then next to that, they're very distinct colors. So this was an indication after we added the sodium hydroxide and after we incubated it for 72 hours at 40 degrees Celsius. Then we observed a spectrometer graph using the UVVI spectrometer. We observed the surface plasmon resonance peak at 440 nanometers. And this was the second indication of which we got that we successfully synthesized silver nanoparticles. So what we assume happens here is when we add the sodium hydroxide, the protein kind of unfolds. And when it unfolds, it exposes these hydroxyl groups, which then reduce our silver ion into a silver nanoparticle. Going back to BSA, I just want to mention some advantages of it. So it has an avid binding ability, it's very stable, it's very water soluble, and it has a long plasma circulation time and a half-life of about 19 days. Can I have the next slide, please? So here are our preliminary results. So I can see here that on the left-hand side, we looked at the effect of silver nitrate on the formation of our silver nanoparticles. So we used the UVVI spectrometer here again and varied the concentration of our silver nitrate, and we kept the concentration of our BSA constant. And here we observed that as we increased the concentration of our silver nitrate, the surface plasmon resonance peak also increased with that. And so we got a higher concentration of our silver nanoparticles. If you notice here as well, the width of our surface plasmon peaks also increased, which suggested that this was due to polydispersity. We used the full wavelength half maxima method to estimate the size of our nanoparticles to be about 50 nanometers to 80 nanometers for both concentrations. On the right-hand side, we investigated the effect of BSA on the formation of silver nanoparticles. So here we varied the concentration of our BSA and we kept the concentration of our silver nanoparticles constant. Here we observed a completely opposite result trend. So as we increased the concentration of our BSA protein, the concentration of the silver nanoparticle formation decreased. And this was seen by the decrease of the surface plasmon resonance peak. This meant that our concentration of silver nanoparticles decreased, the size potentially also decreased, and now we had a low polydispersity. Here we had the question of, could the encapsulation of the silver nanoparticles be the reason for these results? Because then the light wouldn't be able to detect these silver nanoparticles and show us the absorbance required. So I'd just like to note that small angle X-ray scattering and TEM studies are actually currently in progress to answer this question for us. Can I have the next slide, please? So we looked at the anti-cancer properties of our silver nanoparticles. Here we use the sample of 3 to 5 volume to volume ratio of our BSA to silver nitrate, and we also use the cell line triple negative breast cancer cells. We obtained a control, and then we added 10% of our silver nanoparticles, and we added 90% of our silver nanoparticles. So in the control image, you can see these are healthy breast cancer cells, so they're not affected by any silver nanoparticles. And you can see that they're proliferating and have kind of like a spindle shape. When we added the several concentrations of our silver nanoparticles, we observed that they actually lost the spindle shape and they started to die. So here we concluded that the silver nanoparticles showed us dose-dependent toxicity against this particular breast cancer cell line. And after 24 hours after the treatment, we came back and we saw that the cells actually showed us typical signs of apoptosis like cell shrinkage and membrane blebbing. Studies using healthy cells are also in progress currently. Can I have the next slide, please? So in conclusion, I'd like to say that we have successfully formed stable and spherical silver nanoparticles using the protein bovine serum albumin. The protein played 2 parts in this research. So it acted as a role of stabilization and reducing agent to reduce the silver ion into silver nanoparticles. And we observed as we increase the protein concentration, we seem to form a more stable aggregation and encapsulation of these silver nanoparticles, but this does need to be confirmed by using TEM and SAC studies, which are currently in progress. And our preliminary studies give us really promising results when it comes to our silver nanoparticles and their effect on the breast cancer cells. What we plan on doing, what our future direction is we want to look at the influence of pH solution on the formation of our silver nanoparticles. We want to look at the antibacterial properties and whether they even have antibacterial properties and apply them into in-depth cancer studies. And we want to look at what the exact nature of our silver nanoparticles are, whether they're core shell, whether they have fractal aggregates, or even other shapes. And we want to explore the targeted cell therapy. So we want to be able to get those nanoparticles to really look at the breast cancer cells and only attack those. We also want to look at the fluorescence quenching using the silver nanoparticles, and these can play a role in the sensor applications. And we also would finally want to look at the use of other proteins in the development of these silver nanoparticles and in the synthesis of these silver nanoparticles, and be able to apply them even beyond cancer therapy. Lastly, I'd like to acknowledge Rcsi Bahrain for their financial support, Dr. Fatima Al-Hannan and Dr. Edwina Brennan. Thank you very much.
Thank you very much indeed. An excellent presentation. So it was really interesting to see the kind of effect that the silver particles actually had on the cells. And you mentioned that there was apoptosis there. Was that just visualizing apoptosis, or did you actually measure apoptosis, say, with the tunnel method or whatever?
No, we didn't get to measure the apoptosis, but we did observe, like I mentioned, membrane blebbing and cell shrinkage, which gave an indication of apoptosis.
And did you measure LDH as a kind of a measure of cell necrosis? Because obviously cells can die in a number of ways, and apoptosis is one, but obviously, did you measure any cell necrosis?
No, we didn't, but I would take that into consideration and apply that into our future direction.
And so what do you think the mechanism is of silver? Is it just a decrease in inflammation?
Well, I know that it has, it's confirmed to have antibacterial properties, but with cancer therapy, it's relatively new. So I don't think that we definitely know the mechanism of the silver nanoparticles, but as a group, we would like to really target them and stop them from affecting the healthy cells around them and only have them affect the cancer cells themselves.
And you mentioned that BSA specifically you've been using. Have you used any other kind of carrier proteins?
No, but as I mentioned, we are looking to incorporate that into our future work. So we want to look at the other proteins and find out how we can synthesize nanoparticles from those.
Fantastic, Rana. Thank you very much indeed for an excellent presentation.
Thank you very much.
Have the next slide, please. Okay, so finally, the last presentation in this section. Can you just go back one slide? Thank you. Is presented by Dr. Gayatri Narayanan, which is mentees' perception of mentorship in post-clinical training during integrative practicum among fourth-year nursing students. Dr. Gayatri, the floor is yours.
Good afternoon to all. It's my pleasure to thank the organizers for giving me this opportunity to present my presentation. And actually, my topic is a little bit different from the previous presenters. It is talking about the research which is done among the nursing students. Next slide, please. Next slide. Yeah. So in this presentation, I'm going to talk about the introduction to the topic of the mentorship and what are the benefits of the mentorship and statement of the problem, methodology, and the data collection methods, results, and summary. Next slide. Yeah. Next. One more click. Yeah. So the mentorship, the mentoring is inevitable in all our spheres of life. Each and every step, we need someone to guide us. So it is not exceptional in the nursing field. So generally, the mentoring implies a knowledge or the competence gradient in which the process contributes to a sharing of advice or expertise, role development, and the formal, informal support which is given to the new person, that is a novice person. So it is not exceptional in the nursing field because really, because nursing, it's a skill-based profession. Because especially when they go to the clinical, and really they need someone should be there to guide the student, especially the students who are in the integrative practicum. That means during internship, once they complete all the courses and they'll be going for a complete clinical training. So the clinical training, that's a time which is very crucial to prepare the students for as a pre-step for the graduation. So this period is a very, very important period for the nursing students for the overall development to become an absolute professional. So there, the mentorship, it is very, very important to provide the better adaptability to the profession. Otherwise, the students, they may not be able to stay in the profession for a longer time. And also the role conceptions, because the mentors will be playing as a role model, and by seeing their role model and what they're as, like they'll be copy everything, even the communication skills, the specific skills, and whatever the skills they play in the clinical area. So they'll be playing as a role model for nursing students, and they'll be conceiving that as a role conception and the nursing performance and the role socialization for the nursing students, than teaching as a traditional clinical teaching model. That usually what we used to place the students in the clinical area, the faculty used to go and guide the students wherever they have the doubt or wherever they want the guidance to proceed further. So this mentorship model, it's very important and crucial to have a successful outcome for the nursing profession. So it really fulfills the gap, the know-do gap. That means the knowledge, whatever they are gaining the knowledge in the classroom setting, they will be translating the knowledge into the clinical area, that is doing. So this one, the mentorship fulfills the integration of the theoretical knowledge into the clinical knowledge or into the clinical skills. So that's why this topic is very important, especially for the nursing students in the integrative practicum. Next slide, please. Yeah. So actually the mentoring here, the study was focusing only the clinical area. So the mentoring the students in the clinical placement in the clinical area, it plays two major role. That means facilitating the students' learning. Learning, not only the learning, what the learning of basic procedure, basic skills. It is not enough to become a complete nursing professional. It is beyond the preparation. So it creating a supportive learning environment, not only from the mentor. The mentor is a channel, and she is creating the channel to amalgamate all the learning resources from the clinical environment to supplement for their learning purpose, or to augment their learning process, and thereby enhancing the individual learning process, and they'll become the successful professional. And also strengthening the students' professionalism in terms of empowering the development of professional attitude and identity. So knowledge alone, it will not serve the purpose. In the nursing profession, we need the knowledge, attitude, and the skill. So all the three should be amalgamated in a perfect way, then they become the complete professional, a successful professional in the nursing. So thereby it enhances the attainment of the professional competence when they complete the nursing course before they enter into the job. Next slide, please. Next slide. Yeah. So the mentoring, the outcome of the mentoring, or the benefit of the mentoring, we can say that, and if the mentoring is not going in order, or if it is not effective, what will happen? Ineffective mentoring results in the poor self-esteem. Yes. Because the students, they feel that they are lost, they are not supportive, and nobody is supporting them, and nobody is guiding them in the clinical area, and it results in increased stress and anxiety, and that might lead to their practices. That means, example, even the doing mistakes or errors in the medication administration, and decreased attention span, because they are not oriented, because no one is giving them a clear guidance what to do and what is expected from them in the clinical area. And decrease the sense of purpose, and sometimes they feel lost, and I don't know why I'm doing this, and I don't know why I'm standing here, I don't know why I have to do this procedure, because without any knowledge, without any guidance, so they will just have this decreased sense of purpose in the clinical area, and finally it leads to student burnout. So at the result, even they may leave the profession. Okay, so the effective mentoring results in, yes, so the effective mentoring, it depends upon the mentoring preparation. Okay, so who is doing the mentoring role in the clinical area, they should undergo some sort of the mentoring preparation program. So 3 years back, the College of Health Science, they implemented a mentorship program for all the nurses working in the Kingdom of Bahrain. That mainly it was focusing on the governmental sector, because our students used to get the training from the government sector. So they have chosen the nurses who are willing to take up this mentorship course, and they have undergone this training. So after this training, this study was conducted to evaluate what is the perception towards the mentorship, and how far the mentors were helpful and in different dimensions for completing this guiding process. So the effective mentoring, it not only depends upon who is just taking the role of mentor and can be result in the effective mentorship. It is not like that. So the mentoring needs the mentor preparation, then they will take up as a mentor role, and it leads to the effective mentoring. It results in sense of belonging, increased self-confidence, and good working relationship between the mentor and the mentee, and thereby it reduces the stress and anxiety among the student, and it promotes the positive professional development. Next slide, please. Okay, so based on this concept, a study statement of the problem, a study to evaluate the mentee's perception of the mentorship during the post-clinical training during the integrative practicum among fourth-year nursing students. Next slide. So the study had 2 objectives: to measure the students' perception of the mentorship and to associate the background variables with the students' perception. Next slide, please. So the study was a quantitative, non-experimental, descriptive cross-sectional survey, and the permission was obtained from the institute, from the college, as well as from the EOB for conducting the study, and written informed consent was obtained from the students to participate in the study. Next. The sample size was 188 students enrolled in that course, and non-probably convenient sampling method was adopted. Next. So the self-reported questionnaire was distributed to the intern students and result. Totally, actually, we have recruited 210 students, but only 180 response we have received from the students. Next. So after the data collection, the data coding was done. Data analysis used by using the descriptive and the inferential statistics. Now the results comes. Next slide. Next slide. Yeah, so the data collection was done through the Morgan scale. This is a structured scale, and it was developed by Morgan in the year 2015 to evaluate the mentor behaviors in the 3 dimensions by professional development of the nursing student, psychosocial support for the nursing student, and facilitating learning in the clinical area. So it consists of 47 questions in a 5-point Likert scale, and ranging from not important at all to not important, not sure, important, and quite important. Yeah, next slide, please. Okay, so the analysis result shows the majority of the students were the age group of 21 to 22 years, and most of the students were female gender, because naturally the profession, it is like a female dominant profession, and majority of students were female students, and the majority of them got married. Next slide, please. Next slide, please. Yeah. And regarding the number of years they spent in the clinical area.
You're really going over time. You've got 2 minutes to go, okay?
Thank you. Yeah, so the number of years they spent, most of them spent the 4 years, and most of them were scholarship students, and the cumulative grade point of average score, it was about in the range of 3 to 3.49. Next slide, please. Next slide, please. Yeah. So here, this is the core result of the study, and all the components like facilitative learning, professional development, and the psychosocial support was significant at P less than 0.001 level. All the components are significant. So they were very much satisfied with their mentorship guidance in the study. Next slide, please. So this correlation shows the socio-demographic variables with the study outcome, the perceptions of the mentorship, and there was a negative correlation in the gender and the facilitative learning, and positive relationship with gender and the professional development and the psychosocial support. And the marital status, yes, there were positive and the negative correlation, and age, all the positive correlation, and CGPA, all the negative correlation. Sponsorship, there was a perfect positive correlation, and the number of years spent, that was all the positive correlation with the demographic variables and the study outcome. Yeah, next slide, please. There was no significant association between the study, the outcome, and the demographic variables. By using we have used 2 tests to do the relationship, Mann-Whitney test and the Driscoll-Wells test, but both the study results gave there is no relationship between the variables and the study outcome. That is perception towards the mentorship. Next slide, please. Yes. So to conclude, to sum up the study results, mentoring relationship had a positive effect on the career satisfaction and the intent to stay in the nursing profession as a lifelong profession. And successful mentoring is achieved through adequate resources, formal preparation and education of the mentors, and increasing confidence in the clinical placement learning. And also it helps the mutual relationship and role modeling of the mentors, plays a key role for achieving the successful mentorship. And intern-nursing students have a significant positive perception towards the mentor in terms of facilitating the learning, professional support, and the psychosocial support. So these study results may be based on the internship, the mentorship program, which was implemented for the training for the mentors. That could be the positive results of that. Thank you so much.
Right, thank you very much indeed for your presentation. So who's best to be a mentor? Should it be kind of a peer-peer, so that it's someone close to the kind of student? Should it be a newly qualified nurse? Should it be a senior nurse? Who's going to be, is there studies to show who's best?
Actually, to be frank, the peer-assisted learning from your point of the peers, they can be the mentors, but they cannot be as a perfect role model of the mentors. The mentors, they should have some specific characteristics to be the mentor. Must be professionally competent and the senior most nurses, so they have to fulfill certain criteria to be the mentors. But the peers cannot be the mentors. They can be like just exchanging or sharing the information.
Okay, Dr. Pereira, thank you very much indeed. And now I'm afraid I must close the actual conference because we're going over time. So first of all, I'd like to thank our patron, His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al-Khalifa, the Chairman of the Supreme Council of Health. I'd like to thank all our keynote speakers for their excellent presentations. I'd like to thank and congratulations to our 6 most highly rated abstracts who presented already here today. And I would like to thank you all for attending. And I hope that you've enjoyed it as well as learned something. Thank you very much indeed, and have a good day.